Everybody in the room, hold your finger up.
Knock Ward 10. Yeah, quorum, I guess. This little light of mine.
I always like to say that Katie gives me the finger.
It's gonna be recorded for all time.
Yeah.
It'll come back on.
Oh, half a finger.
The screenshot, every time you look at the video, will start with you holding the finger. I think we'll.
There we go.
I can look.
Are we loaded? Okay, welcome back to committee. The room filled up a little bit since we left. That's can either be good or that could be bad. Let's hope it's good. Hey, we're a one-topic afternoon, and although it's one topic, it's a big topic. And we have a lot of people to testify. The topic is maternity care and child care. There is no bill, as I recall. This is a discussion. And for those who will be remaining on the committee or who will be remaining in legislature, this is a topic you will hear more about. And we'll be discussing in future sessions, in future interims. So with that introduction, we're going to start with LSO, I believe, has some statistics, and I don't know who has that. It looks like Anna.
Mr. Chairman, I have something and then Clay does as well. So I think I'll go first and then he can go after that if you're
You
okay
can
with that.
fight over it, or whichever wants to go first, that's fine.
Mr. Chairman, members of the committee, this memo was actually written by Emily Wonkin when she was here over the summer, but she's gone back to school, so I'll take over describing it to you. Last June, the Labor Committee requested additional information on the Maternity Care Nursing Workforce Expansion Program, otherwise known as MatCare. The MatCare program is a grant funding program for established accredited nurse midwifery programs administered by the Bureau of Health Workforce and the Health Resources and Services Administration. The program was created to address the United States high maternal mortality rate, and applications were accepted between June and July of 2023. At this time, it's unclear whether the program will take new applications at some later date. MatCare grants can only be used for established nurse midwifery programs, and eligible applicants include accredited nursing programs, nursing centers, academic health centers, state or local governments, and other public or private nonprofit entities deemed appropriate by the Health and Human Services Secretary. Grant beneficiaries must be licensed, registered nurses eligible to work in the U.S., enrolled full-time in an advanced nursing education program to become certified as a nurse midwife, and maintain academic standards by the recipient institution. You can see at the bottom of page 2, there's a list of recipients of the grants, and then grant recipients' programs must include the following purposes: to increase the number of certified nurse midwives and diversify the maternal and perinatal health workforce, to expand maternal health training and enhance curriculum, and to strengthen community-based training partnerships. The recipients of MatCare grants generally use those funds to provide scholarships and stipends for students seeking to practice in rural and underserved areas. And that's pretty much the entire memorandum, but I'd stand for any questions.
Any questions on that memo, committee? Seeing none, go ahead.
Mr. Chairman, members of the committee, Clayton Caldwell, Wyoming Legislative Service Office. I have provided for the committee a memo that describes the oversight requirements for physician assistants and certified nurse midwives in different states in the U.S. And today I will briefly summarize the contents of this memo, and then I can stand for any questions. So to get started, the Wyoming legislature passed a law in 2021 removing the requirement that physician assistants be supervised by a licensed physician. And so now 4 states, including Wyoming, do not require physician assistants to be supervised in order to practice medicine. 25 states, like Nebraska, do require physician assistants be continuously supervised by a licensed physician, and 21 states, including Colorado, Washington, and Idaho, allow physician assistants to enter into a collaborative agreement instead of being supervised. Speaking on certified nurse midwives, 30 states, including Wyoming, allow certified nurse midwives to operate independently of a physician. and 16 states, including Nebraska, require certified nurse midwives to enter into a practice agreement with a licensed physician in order to practice. That's a brief summary of the contents of this memo, but I can stand for any questions.
Questions, committee? Very quiet committee. Thank you very much. And that's it from LSO? It is. Lots of head shakes. With that, let's bring up Department of Health. And we have 4 chairs, the appropriate number. Welcome, gentlemen. Introduce yourselves, whoever wants to take the lead. I suspect it's Franz, but I don't know. I lied. Go ahead, introduce yourselves and tell us everything you know.
Thank you, Mr. Chairman. Lee Grossman, State Medicaid Agent with the Wyoming Department of Health. Joined to my left by Franz Fuchs, Chief Policy Analyst with the Director's Office. To my right by Dr. Paul Johnson, the Medicaid Medical Director. And then to his right, Jesse Springer, Deputy Division Administrator at Healthcare Financing. So we've got the brain trust here. We're overwhelming with numbers, even if we'll do our best to keep it brief. We're going to provide a brief amount of information focused on doula coverage. That was the ask, as we understand it, from the Department of Health today. We've obviously provided quite a bit of information, including at the Afton meeting in particular. So don't want to repeat ourselves as much as we can avoid that. Franz is going to, Mr. Fuchs is going to provide some projections in terms of what some of the numbers could look like with doula coverage, but wanted to provide just some really basic information that this is indeed a service that can be federally approved, so we can get federal match to enroll doulas and pay doulas as Medicaid providers. This is the case already in 12 states plus the District of Columbia. And most of those, just from a timing perspective, I believe the first state that added this as a covered benefit was back in 2014. And so the most of those 12 states plus DC have really been in the last few years. So it is a growing trend that those of us in Medicaid hear about from other states in terms of their analysis of this benefit. And I would, before I kick it over to Mr. Fuchs, I would be remiss if I didn't correct my introductions. I just looked to my right. Notice I made Jesse Springer a doctor and the medical director. So please excuse that. I'm sure they'll introduce themselves when the time calls for it. But with that, I'll turn it over to Mr. Fuchs.
And that is Mr. Fuchs to your left. You are correct. Go ahead, sir.
Thank you, Mr. Chairman. Again, members of the committee, my name is Franz Fuchs, Policy Analyst at the Department of Health. Chairman, you asked us to just kind of give you all an estimate of what it would cost and kind of what you'd have to do to add doula coverage to Medicaid. So I'm just purely talking from a healthcare financing perspective, nothing, from a clinical perspective or anything like that. The first thing you need is a statute change. So all the Medicaid covered services are in 424103. So a suggested area could be under the, for example, Romanet 9 is currently midwife. That could potentially be changed to like pregnancy support services, and doulas could be added as a sub-Romanet under that. That would be our suggestion. But at the end of the day, the service has to be listed in that particular section of statute. The second thing we need is money. Basically, we estimate that we need an appropriation of approximately $300,000 of general fund and $300,000 of federal fund for a biennium. And that is based on an annual cost estimate of $300,000. Which, there's a lot of assumptions here. We don't obviously have claims experience, but we'd be assuming around 10% of Medicaid moms delivering would elect to have a doula. And that'd be 180 deliveries. And we'd estimate we reimburse approximately $1,500 for those doula services, whether it's split up in terms of visit rates or a bundle delivery fee or whatever. So that's the cost estimate, the statute change. We did, do some research on the potential benefits. There were 3 decent randomized control trials that look at this issue, and they found beneficial effects regarding the shorter length of labor, higher APGAR scores for the baby, and then also the mothers were more likely to initiate breastfeeding, put infants on their back to sleep, use car seats at 3 weeks, and read to infants. These are all relatively pro-social outcomes. However, there's nothing that indicate there'd be offsets from Medicaid standpoint that could, say, pay for that service. So we are assuming 100% cost and no ROI per se. So with that, Mr. Chairman, happy to stand for any questions you may have.
Not a question, just a suggestion. We are considered the the group of initials here. Can you clarify for everyone what APGAR means?
Mr. Chairman, that might be a trick question. I think might be a person. I don't know if it stands for something, but I'd have to ask Dr. Johnson over here.
I'd pass it on to the doctor, the one that was just newly anointed. Oh. Go ahead, Dr. Johnson.
I don't want to embarrass myself. Paul Johnson, Mr. Chairman, members of the committee, I believe it is named after Dr. Virginia Apgar, and it's a scoring of an infant after, or neonate after birth.
Perfect, thank you. Somebody did name us the acronym committee, which I kind of like better. Labor, Health, Social Services. It's much easier to say. Okay, any questions for Mr. Fuchs, committee? Nobody? Oh, yeah, go ahead, Mr. Chairman.
So there's no data to indicate that other costs go down if people are using a doula, and there's pro-social behaviors, but they don't have an economic, financial tie to less people going into a hospital setting or less people utilizing a full OBGYN as opposed to a doula and maybe a midwife, because I would assume you can be a midwife and a doula. There's no, I guess my question is, there's no financial savings that you found on the other end of the equation in utilizing doulas?
Mr. Chairman, sorry, Mr. Co-Chair, that's correct. All of those studies, I think the main thing we would have looked for would have been a reduction in cesarean sections or potentially anesthesia, and all the studies found no statistically significant effects on either of those outcomes. So these are all, of course, beneficial outcomes from a social society perspective, but quantifying the benefits to society and particularly the benefits back to Medicaid would be, they'd be very small and speculative.
Senator Hutchins, I see a hand, and then I'll get to you, Representative Ward. Go ahead, Senator Hutchins. She's saying no. Okay, I just saw a hand over there. Representative Ward, go ahead, ma'am.
Thank you, Mr. Chairman, and I'd like to clarify for Representative Swanitzer. So you can be a midwife and a doula at the same time, and when you're acting as a midwife, you could also be practicing as a doula, but you cannot be practicing as a doula and also be employing midwife skills, because as a doula, you sign a scope of practice if you're a certified doula that you don't practice medicine. Right, so if you're acting in the doula capacity, you can't be a midwife. But if you're a midwife, you can do the things that a doula would do, yeah.
Further questions? Representative Hornock.
Try that one. You said 100% cost and no ROI, and that's, I'm not sure what, have you looked at, it seems like instead of paying for reimbursement of somebody going to a hospital, you're paying for reimbursement for a doula. So it seems like there's a zero cost factor in that kind of situation. Is that incorporated into your cost factor? And then I'm curious where you get the $300,000 state side and $300,000 federal side numbers, just to kind of set the stage for it.
Mr. Fuchs.
So, Mr. Chairman, Representative Hornock, doulas they will accompany the mother and support the mother in any childbirth setting, whether it's at the hospital or at home. The literature does not indicate that women tend to substitute and go for a home birth when they have a doula compared to going to a hospital. So it's kind of an additive service. What it might replace is, I think the most plausible replacement would be a C-section. So potentially a mother decides to deliver vaginally as opposed to having a C-section, and there may be a potential cost savings on the Medicaid side. But the studies we looked at did not indicate any statistically significant difference there. So that's how, when we say there's no necessarily ROI, it's, that might have been, that's plausible. You could imagine that being possible. And there was some of, effect in that direction in these studies, but it was not statistically significant. As far as the $300,000 figure, that comes from estimating, so we have about 1,800 deliveries per year in Medicaid. About 10% of those would likely elect to have a doula, and that's, again, an estimate. So that's 180 deliveries, and then we estimate a bundle of about $1,500 to pay the doula. So That's $300,000 of cost, or 270 something, rounding up to 300,000. And then it's a 50-50 split with the feds. So 150 per year of state funds, 150 federal, but then you biennialize it for the 2-year biennium. So that comes up with our total appropriation recommendation of 300,000 state, 300,000 federal for the biennium.
Follow-up, go ahead.
Thank you, Mr. Chairman. Isn't that already covered, though, in what we allocate for Medicaid births, basically? So we passed the Medicaid expansion for mothers, for pregnant mothers and things like that. Wouldn't then you be paying the doula just instead of paying the hospital costs? Wouldn't it be a zero cost factor? You'd just be paying one place over another. You'd still have the same amount of funding required. The funding wouldn't have to be increased necessarily. It'd just be going to another source instead of, it'd be going to one versus the other. And then, sorry, you said the cost factors are just based on studies that were done. Is that studies in Wyoming? Is that studies that you looked at nationally? Just some questions.
Mr. Fuchs.
So, Mr. Chairman, I'll take the last first. Those 3 studies were randomized control trials that were conducted in various places around the United States. We tend to rely more on RCTs because they are the gold standard for scientific evidence. Every other study that is out there will generally be an observational study, and that has a lot of potential problems with the effects being confounded by, which kind of mothers like to have doulas. They may be more likely to go to a home birth anyway, right? So you want to randomize the doula assignment in order to get the effect of the doula isolated. As far as your first question goes, I think, so Medicaid, obviously the biggest expenses in Medicaid for deliveries are the hospital and the OB/GYN that are paid for separately for the hospital stay and then the physician services. So adding doula services to that mix, in order for them to be cost savings, we would have to reduce the number of mothers going to the hospital and have more mothers giving birth at home, potentially. That effect was not seen in these studies, in that literature, so we would not assume that as a cost savings.
Further questions, committee? Go ahead, Representative Penn.
Thank you, Mr. Chairman. So would it be possible to say that to mothers, you have an option of having a doula if you choose to have a home birth? If you choose to go to a facility, to a hospital, then we will not cover a doula. Now, of course, if they chose the doula option and chose to have a birth at home and something happened and ended up in a hospital, then that would be a separate circumstance. But I'm wondering if people would choose that option instead of going to a hospital. Is that something that could be done? And second question is, what on average for a normal vaginal uncomplicated delivery does Medicaid pay for a hospital admission birth situation?
Go ahead, Ms. Fuchs.
Mr. Chairman, Representative Penn, I will defer the legal question or on whether we can kind of pose that option to mothers, to our Medicaid folks. But as far as the costs, the average Medicaid birth cost, I think, is around $6,000. I have not, that includes all births. We have not disaggregated the home births, which I think are very, very small fraction of those from the hospital ones. We could potentially get that to you, but I think it's roughly 50-50 split between the hospital and the OB/GYN, because I think there's a $3,000 bundled rate for the OB/GYN. So yeah, I'll stop talking and defer to people who might know better.
Okay, further questions? Oh, go ahead, Lee.
Mr. Chairman, Representative Penn, I'll ask Dr. Johnson to weigh in on some of that piece too. Thinking of the question in particular of can we, paraphrasing here, lock in a Medicaid pregnant woman to essentially a home birth track or the hospital track, if you will. I don't know if that's something that we're able to do, frankly. We'd probably have to do a little bit more research. But Dr. Johnson, I believe he might have some more to add in terms of some of our abilities there.
Dr. Johnson, add away.
Mr. Chairman, Representative Penn, I believe there are some considerations of equity in that we can't provide a service just to a certain subset of Medicaid beneficiaries. So we can say, well, you could have a doula if you delivered at home, but not if you chose to go to a hospital. And of course, there'd be confounders as well if the intention was to deliver at home, but then something happened during the pregnancy, or there was a change of mind. We certainly couldn't preclude somebody from delivering at the hospital.
Further questions, follow-up? Seeing none. Anything further, gentlemen? Go ahead if you got more for us. Wow, got off easy today. Thank you, gentlemen. Now we have those 4 vacant seats. I believe we got 3 or 4 more that would wish to come up from the governor's task force. We'll call this the Task Force / Wyoming Medical Society. It's a combo group. Go ahead. Ms. Bush, I believe you look like you're going to lead off.
Good afternoon, Mr. Chairman, members of the committee. Sheila Bush, normally with the Wyoming Medical Society, but today wearing specifically a hat on behalf of the governor's task force on health and specifically the OB primary care subgroup. Joined to my right with me is Dr. Jacques Beveridge. He's a practicing obstetrician and gynecologist here in Cheyenne and also a member of the task force. Next to him, Dr. Christy St. Clair. She's a third-year resident here at the Cheyenne Family Medicine Residency Program. And next to her, Dr. Evan Norby, who is the director of the Family Medicine Residency Program here in Cheyenne. So I wanted to offer that at the previous meeting, the task force was requested to come back with some ideas and proposals and just talk about what we think might be most helpful to contemplate. Again, these are all conceptual. We don't have any requests specifically for legislation today. So I'll try and be brief, and then we'll probably circle back and talk in more detail about a couple of them. So to make it easiest, we broke down our maternity health deserts into what are the primary challenges or what are the biggest problems. And those kind of boil down to physician and healthcare professional workforce, geographic disparity or long distances from people to healthcare services, and sufficient patient volume to support the current infrastructure or be able to grow it in the future. Our solutions are proposed were an OB fellowship here at the Cheyenne Residency Program, which is where our family medicine residency graduates do their 3 years here. A fellowship would allow them to do a 4th year, would be concentrated on obstetrics. Supported rural rotations, similarly family medicine residents being able to rotate through rural areas of the state and get experience in some of our smaller hospitals who are doing OB. Risk stratification, this came from a presentation we heard from the state of Alaska. They have done a really nice job recognizing when moms are low, moderate, and high risk, and then making appropriate decisions closer to delivery. Meaning if you're low risk and you want to stay in your home community and deliver with a midwife or a family medicine OB or whatever that situation might be, that's perfectly fine. But as you ratchet up on that risk scale, maybe moving a mom at 32 weeks or 34 weeks, moving her to a location temporarily in the state, if we could keep her here safely, where it wouldn't be an emergency transport, but instead a planned temporary relocation to an area where more higher level services are available. Increased Medicaid reimbursement. The last that we checked, we've asked the Department of Health when physicians last took a pay increase on Medicaid. No one can tell us. It was far enough back. It's sort of just not available at this point. I've been with the Medical Society almost 20 years. I know it hasn't happened in that time. And we've seen a round or two of cuts though. Liability reform, which we had talked about this morning, which can look like a lot of different things, from strict caps on non-economic damages through some of those other things that I had mentioned. Regional mobile care teams. This idea came from the American Heart Association when they were addressing stroke. They explain it interestingly as instead of a hub and spoke, a spoke and hub. I don't know, really, that's not very helpful, but it's what they say a lot. Meaning that if a mom is in crisis, that there would be regional teams of physicians who could mobilize and get to the mom quickly, as long as that facility she was in had the resources that they needed for a far less cost. You could move physicians there rather than the cost and sometimes trauma of moving mom. And then the final, or not final, but another is the state-sponsored physician recruitment or training. Similarly to the way we structure WWAMI, maybe an idea where we can create exchange programs or relationships with out-of-state OB fellowships, allow those women to go to those fellowships and then come back. And again, similar to WWAMI, owe the state a payback of some kind. So, sorry, I have to move my page here. Enhancement of education programs for advanced professional practitioners or advanced practice professionals. I think that that can look like a lot of different things. The community colleges are in conversation along with UW with midwifery training and education, more resources to not only physician programs, but all of the advanced practice professionals for loan repayment and any support there to incentivize and recruit them to the state. The residency program, both a GME council and a GME consortium, they're two different things, but similar in the sense that the consortium helps elevate the state's probability of receiving and accepting a different funding resource. And the council is essentially a group of individuals who come together and, I don't know, discuss ideas of how to enhance and elevate, further support GME in the state. Both of those are in conversation with the University of Wyoming and the Board of Trustees and sort of in the works. So with that, those are the high-level proposals. And I'm going to give the floor over to my friends to the right to talk in a little more detail about a couple of those.
Very good. Any selected order, or are they all your friends? Just across the board. Okay, go ahead. Right, or my right to your left. Okay, go ahead.
Thanks, Mr. Chairman and committee. I think I would lead off. I'm Dr. Jacques Beveridge, and I'm an OBGYN from here in Cheyenne, a proud Wyoming native who returned to the state on the state-funded program at the time, different than WWAMI now, but the contract program, attended Creighton, came back, practiced in Lander for about 10 years, solo practice. And interestingly, I got burnt out after that. And like many folks in our small towns, I decided to leave, but I wanted to stay in my wonderful state. Came back to Cheyenne, my own town, joined a group where I actually have a call schedule now and can come do things like this. And one of my partners is up delivering the babies. So, and I've been here long enough that people ask me for my help on some of these topics and have been in state for my entire practice. So the first topic that Sheila talked about of expanding, or that we've looked at on the governor's OB subcommittee. I mean, there's so many ideas and topics, but this of getting residents to go to these small towns and practice, and how do we make that more likely? And this idea of an OB track for our residents, Casper currently has an OB track. Cheyenne does not, but we've talked about doing that versus actually instituting a true fellowship. So instead of just some added focus during residency, adding a whole nother year where their focus is specific to obstetrics, there's a lot of pieces that go into that puzzle. We've come to find out as we've looked deeper and deeper into that. And some of that graduate medical education support is going to be needed. But I think I'll potentially stop there, but introduce Dr. St. Clair, because she is the success story. And she doesn't have the benefit of all these things we're talking about, but nonetheless, this bright, I just get excited. This bright, does anybody have a water? Water? She comes to us from out of state. She comes to us from out of state.
You can pause for a second if you want. We'll
And-
get you water.
Appreciate it.
It might be spiked, but we'll get you a drink.
Hot water, cold water?
I'll be all right.
We never knew that testifying was this stressful.
It's exciting.
Okay, proceed.
It's exciting because we've spent so many hours in these committees talking about how do we keep docs in the state, and despite all these conversations and all these ideas, Dr. St. Clair's doing it anyway, right? So here's a gal from out of state, Georgia, comes to Wyoming because she wants a great residency that teaches her obstetrics. And we're doing that. And lo and behold, she comes here and loves Wyoming and wants to stay in Wyoming. And she is about to go to Warland as a family practice OB, right? And she's gonna stay here in the state. And the reason I asked her to come is to point out, how do we replicate this? This doesn't happen all that often. And we have all these great ideas, but we need some help making them happen. So tell us a little bit. Thanks.
Well, thank you for that introduction. So my name is Chrissy St. Clair. I'm currently a third-year resident at the University of Wyoming Family Medicine Program here in Cheyenne. I am originally from Georgia, just outside of Augusta. My hometown is about the size of 1,000 people. So I'm very used to small town life, and had always planned to go back to small town life. Originally, the plan was to go back to Georgia. And I had done all my education in Georgia and kind of needed some adventure in my life. And so was looking elsewhere to go to residency. Found this program in Cheyenne that had all of the things I wanted, including really good obstetrics care, unopposed residency, which was really important to me. Unopposed for family medicine means that there are no other residents in the hospital competing with you. In a lot of larger academic hospitals, particularly in capital cities, there are OBGYN residents, internal medicine residents, residents of all kinds, and you're competing with them to get procedures, deliveries, interesting patients, all of the above. And so if you're a family practice doc who wants to do all of the things for all people, you need good training in all those areas, and you don't have time or energy to compete for all those things. So going somewhere unopposed where they are welcomely allowing me to do all of those things and teaching me how to do them was really important. I get great sports medicine education, which is really important to me. We cover Division I athletics with the University of Wyoming, which I love. So it kind of checked all the boxes that I was interested in. Also gave me an opportunity to have an adventure in the West. So here I am. I came to Cheyenne about 2 years ago and loved it. The city's a little bit big for my taste, but the mountains are wonderful. I love the snow. I learned to snowboard during my first year here and absolutely fell in love with the winters. So the winters and the snow kind of kept me here and made me want to stay. I fell in love with the mountains, and I don't think I can ever live somewhere without mountains again. So I started looking for a job where I could live in a rural town and enjoy that kind of small town lifestyle, where I could live in the wilderness but still be within my call time. And that was hard. I knew I wanted to do part OB practice, but I didn't want to completely give up medicine. Finding a job like that was difficult as well. There's a lot of jobs out there where they want you to either do completely OB or completely family medicine, but not both. And outside of Wyoming, a lot of places wanted me to do a fellowship. I was not opposed to a fellowship, but after 11 years in school, I was really ready to be done and was not excited about the idea of doing one more year. So I luckily was able to find a job where I could do part OB and the other half is part ER. And potentially down the line, as I get established in the community, I might transition a little bit away from the ER and more towards regular family medicine clinic. So I'm really grateful for all those things. The reasons I'm very excited about that job in Warland is because they have at minimum 4 providers doing OB care at any time. So my call is 1 in 4 at most. Since I'm doing half OB and half ER, it's half of 1 in 4, which is nice. And it is good to know that my partners will back me up in saying less than 4 partners is very difficult and wears on the provider. So that is wonderful. I'm also really grateful that in Moreland, we have a general surgeon as their first assist in all C-sections. That is a huge luxury. Doing C-sections as a family medicine provider is intimidating. And it is a very huge skill that we don't get as much training as typical OB residents would. So doing that, but having a general surgeon at every C-section with me is really wonderful because he can fix any, bowel perforations or bladder perforations that I might inadvertently cause. So that is amazing. The other things I really liked about going to Warland is that I can live really rurally. I am from a small town and wanted to live in a small town. I think finding other providers that understand that mindset is really important. From what I've heard, a lot of other places have been struggling to fill their OB positions because they're finding people who are not from small towns and don't understand what that's like and trying to incentivize them to go there. And when you don't understand what it's like to live in a small town, realizing those things can be a bit harsh. But when you know what it's like and you want to go there, it can be very rewarding. The really nice thing about my job in Warland is the amount of C-sections they want me to have done as primary surgeon before I start is 50. Currently, I'm in my 3rd year of residency and have a handful so far as primary surgeon. My very first one was as an intern during first year, but the opportunity to be primary surgeon is not as common depending on the situation. It also takes a lot of time to gain the trust of the OBs in town to be able to convince them to let you be primary surgeon when it's their name on the line and their license on the line. So I'm hoping during this 3rd year I'll get a lot more, and my goal is 25 by graduation. Banner has been kind enough to say that if I don't get the amount of primary C-sections that I need before graduation, they will send me to their main campus in Phoenix for a month and allow me to do nothing but C-sections for a whole month under their training there so that I can get enough to be able to go back to Warland and still provide that skill for our community. I think that's all. Thank you very much.
Thanks, Dr. St. Clair, and thank you for the water, whoever grabbed that for me, Mr. Chairman. So just to follow up on that and maybe highlight a couple of the ideas. So one is just the ability to do C-sections in a small town. So Warland would like her to have 50 C-sections before she arrives there. If you look at most fellowships around the country, most of those fellows come out with about 100 C-sections before they go. And most people probably want their surgeon to have done more than less. So there is potentially some advantage to the fellowship, but the idea behind this is how do we get the residents either that we have in our own programs or that would come from the outside the training they need. And there's a number of models that could happen, whether that's state funding, partnering with private. Fortunately, she's going to a hospital that's owned by a very large system. There's good and bad to that. The good is they have the ability to send her to one of their large facilities and polish her off. We see some of our residents leave and go to places that are very small, but they're still willing to take them out of residency even though they haven't had very many numbers at all, and they decide, we'll polish them off here locally. So there's different ways, I think, to do that, but many of the towns require this level of training on top of what she said, the amount of call that's required for these docs to take while they're there. And that, I think, is what's happening in some of these OB deserts as their numbers decline and as their doctors decline. If you're taking call every single night, just like I did in Lander for almost 10 years, it wears you out and you can't sustain that. You just can't do it. And there are a few people who will do that, but I think they're becoming fewer and far between. So that's kind of one model. I would also speak to maybe 2 other models. One is what I would call the Alaska model. And I think there is some real room for this in Wyoming, where we could say, especially in these deserts or in smaller communities where the numbers are low, but they still want to keep their delivery services, that we essentially follow this Alaska model, if you call it that, where the lowest risk deliveries can be done in these small communities. And as you ratchet up their level of risk, whether it's moderate risk or high risk, these patients can then move on to some of our other towns and facilities to help facilitate the volume in those towns without having to then transport these patients out at the last minute. So if you look at we can ask Medicaid or what have you, but the last numbers I've seen on the number of patients we life flight out, it runs us $70,000 to $90,000 for each one of those life flight transports. I mean, just think of those numbers if those patients didn't have to be flown out, but yet you can pick your community, whether it's, Casper, Cheyenne, Evanston, Jackson, but whatever whatever facilities are taking the higher risk, the patients could go there and get the level they need. They could move there ahead of time. We can get more into that model. And then the other model, which I like to call the Powell model. So in Powell, they decided to just go all in on obstetrics and have spent the money to essentially acquire that 4-person team, 2 physicians, 2 midwives, to help cover their service. But it requires that level of professional service to cover their deliveries, but it doesn't, but they're running in the red. They're taking from all their other services just so they can provide that service in Powell. And so how do we make that sustainable? So maybe a quick Gavin. Thank you.
Before you go on, I got a question for you, Sheila, or Dr. Nodi, whoever can answer this. Of all the hospitals in Wyoming, how many are with general surgeons and how many are without general surgeons?
Mr. Chairman, I would be so cool if I knew that off the top of my head. I do not. What I thought you were going to ask and what I had been looking up was how many deliveries the Cheyenne Hospital averages, given that we're talking about a potential OB fellowship.
We'll
The answer to
pretend I
the
asked
question
that.
you
Go ahead.
didn't ask is they average around 1,000, and 300, between 250, 300 of those annually end up being cesarean sections.
Mr. Chairman? Thank you, Mr. Chairman. Have you guys run numbers to all these different things? And if you have a mobile response team, would you, doctor, since you're not burned out any longer, would some doctors propose to be on those mobile response teams, not delivering a baby or having a C-section? Which brings me another question. Are this mobile response team going to have the polish that 50 to 100 C-sections would give you?
Go ahead, doctor.
Thank you. Mr. Chairman, Representative O'Hearn. That would be the type of work I'd be interested in. You're going to have to find docs willing to do that, and they're going to have to be housed somewhere and at the ready to go. And so it's almost the reverse model of the Alaska model. So you're sending the doc instead of the patient. And in answer to your first question on the numbers, no, this committee has not run numbers. We've really been, and it's a very broad committee with lots of ideas, and we've tried to assimilate some of those for you here today. And I apologize, I forgot your third question.
I think you wanted to know if you wanted to do this. I know that wasn't the question. Go ahead.
I think you already answered that one. There would be doctors throughout the state that have that polish that may come back into the system and help out in some of those areas that are needed.
Yeah,
Go ahead.
Mr. Chairman, thank you. So I believe so, and there's lots of need around the state for docs and docs coming to the state to do the work. So it might be docs in the state. You could have even locums that are already coming to the state. In fact, under the Powell model, they have one local physician who works their system 20 days a week. Their other doc that covers the 10 days comes from Oregon, but is working for the Powell Hospital specifically. He's not a locums. And so you have docs doing this work already and traveling the state. So there already are folks doing similar stuff, but it's arranged ahead. It's not on short emergent notice.
Further questions, committee?
Can I, sorry.
Oh,
I
go
wasn't
ahead,
finished,
Ms. Bush.
sorry. I wanted to offer just a few more thoughts, the first of which I came in with notes everywhere to remind myself to offer for you that in the conversation around maternal health, we have to be very careful to not forget you have a second patient. And so in any of these models that we've talked about, the focus today has been on maternal health and the mother, but there's the baby and the pediatric team that also has to be available to take care of the baby once they arrive. And so while a lot of the conversations seem to focus on the mom and the care team that delivers that healthcare to the mother who's pregnant, we have to be really careful to not forget the necessity of the pediatric team, sometimes a specialty pediatric team that needs to be available. And so when we talk about risk stratification or moving moms to different levels of care, part of that level of care is obviously also thinking about what pediatric services are available. Right now, Wyoming doesn't have a NICU. We fly babies that are 32 weeks and earlier. They leave our state and go to the nearest facility that does have the services that those babies need. Going back to the list of solutions, I wanted to offer two. Not all of these have a legislative component or a public role. So we offered all of them as sort of a picture or a window into all of the conversation that the OB primary care subgroup had. Some of them have a public component to them. Most of them are a partnership or envisioned to be a partnership. And so, for example, the OB fellowship, a lot of that is going to take on the private side individual physicians like Dr. Beveridge being willing to serve as those attending physicians and training. And then the state's role in that is obviously the continued funding of the residency program so that we have those programs available to produce graduates like Dr. St. Clair.
Go ahead, Mr. Co-Chair.
Thanks, Ms. Bush or Dr. Norby. Do we know what that cost breaks down to per doctor per year to have this type of a program for a fourth year? Have we run those numbers yet? It might be too soon. I just thought I'd check.
I don't have the numbers on per doc per year. Dr. Norby, do
Looks
you?
like he has an answer.
So typically a fellow when they're Mr. Chair, Ms. Wanitzer, typically a fourth-year fellow will get paid anywhere between $60,000 to $80,000, depending on the region and the specialty. So with at the University of Wyoming, add that 50% to benefits, and that would be the cost.
Follow?
There's no additional overhead fees for, I don't know, any of the infrastructure or the trainings or I mean, it's got to be more than just salary and benefits. You have to have some fee to have all the other physicians and supervising and clinicals, I would assume.
Go ahead, doctor.
Yes, that is correct. So currently, a lot of the infrastructure would be in place with the way that having the core program present, because it would be a part of the family medicine residency program here, and all of our faculty are currently paid for. Probably the biggest increase from an infrastructure is how the paying for the OBs that would be a part of the fellowship would work out. And I can't give you those numbers. I don't know what that would be.
Very good. Proceed, Ms. Bush.
This is my final thought, and I would just offer that, as Dr. Beveridge said, there are a lot of people on the task force and then obviously on the OB primary care subgroup. Today, I'm presenting on behalf of the task force because Ms. Davis from the governor's office is traveling. And so I want to be really careful and say out loud, some of this presentation lands physician heavy, and we don't intend it that way. There are other folks in the room that I think can offer some really wonderful ideas that are also part of those conversations at the OB primary care subgroup that are in more detail around midwifery education and training, and some conversation we've had around how to not only enhance the relationship between obstetricians and family medicine physicians who want to do OB, but also between the physician community and all of our advanced practice professionals around the state to truly accomplish a team-based approach to creating the safest, highest quality care that we can for our patients in Wyoming. And so because the agenda was structured with the task force and then the medical society next, we decided it would be more efficient to kind of come in together. But I recognize that that can land like it's a very physician-centric presentation, and I apologize for that, but I am confident we have some other folks who will give you really good information on the other folks.
Representative Ward, go ahead.
Thank you, Mr. Chairman. Ms. Bush, you mentioned a second patient, a baby. My question to you is, when does that person become the second patient? Before birth, after birth?
I don't know that that's relevant to this conversation, but thanks.
Okay. Any further questions? Representative Penn.
Thank you, Mr. Chairman. So as I sit through these meetings and think about why have we developed this problem? Because we haven't always had a healthcare desert or a maternity desert in this state. It used to work, and so why is it now not working? And what I keep coming up with is, the healthcare model really has changed. It used to be that we had in our rural healthcare or our rural towns, we had the family doc that saw you from conception until death, right? We had the guy that did everything. He delivered the baby, then he took out their tonsils, then he, did everything all down the line, and that worked when we have small communities and small numbers of patients. But our healthcare model seems to have gone to specialties. And so we see a pediatrician, and then we see a OB, or a gynecologist, and then we see an OB, and then we see an orthopedist if we need this, and so we have all these specialties, and it's difficult for our small population to support all of the various specialties when they only see one type of patient, and we just don't have that population to support it. So my question is, because of course, as you mentioned, government can't fix all of these issues. We have Dr. St. Clair, right, who is the perfect storm, and she loves this rural state that we live in, as we do, but not everyone does. And so in this task force, have you guys discussed at all maybe that concept, or discussed marketing to those who are more interested in providing multiple services rather than specifically looking at how do we get OBs here? How do we get family docs who want to also deliver babies? How do we get family docs who also want to do these other things? That was one of the reasons that I motioned in our last meeting to address or to look into tort reform, because if docs are asked to do something out of their specialty, are they opening themselves up for liability? So is that a discussion that has occurred?
Dr. Beveridge.
Thank you, Mr. Chairman, Representative Penn. So thanks for your comments. And we have talked about that. And I would say Wyoming in general it's a tough recruit in healthcare. And I went through that in Lander, and I even go through it in the largest town in the state in Wyoming with a giant city just south of us. People often can't even contemplate what that means to move to a state with as few people as we have, and they won't even look at it. Now, there are bright young med school grads who are looking for residencies in family practice, but and maybe that's our sweet spot, and that's what I say, how do we replicate this? So I think that idea is a good one, and we have talked about that. I would also talk a little bit to how did we get here? I think there's a number of things. If you look at the delivery numbers in the state, they've gone down every year, even though our population has climbed. And so these small towns specifically, their numbers are really going down. And so it's a volume issue, and you begin to lose the expertise, not just of the physician, but of your support staff and the nursing care, the pediatric care. And I think that's also moved us in that direction. I think specialty care as well, as you mentioned, and folks that we see coming out honestly aren't interested in taking as much call as I did throughout my career. And maybe that's okay. Maybe we've learned something over the years, and after this pandemic, people are certainly interested in themselves and taking care of themselves. And so we're having a hard time finding folks that want to work that hard, I think is also part of it. And the other piece I would add, following up on what Sheila said, is when we look at the other parts of the team, when we hear her data on physician assistants, midwives, how they're supervised or not. We talked about doulas. All those folks can be a real integral part of the team, especially if we're beginning to strategize, categorize risk categories of patients and move them around. And one idea came to mind as I was hearing from the Department of Health and paying doulas. I mean, if you think of a model where in a very small venue, a doula could be providing some of the prenatal care or prenatal visits as relates to the obstetrician, or a midwife could do the same. And then the next level up of high risk could be FPOB with midwife support, et cetera. And you know, Alaska showed us great models for that, but those other parts of the team are very important. It's a long answer to your statement, but thank you.
Further questions, committee? Further answers, panelists? Dr. Nordy got off pretty easy here. He didn't have to talk very much.
Mr. Chairman?
Yeah, go ahead.
And if it is possible, some of those recommendations, I know when the governor's office gets back to send them on to this committee in whatever form. I know we went through a lot of ideas there, but for the future, I think it would be important to have maybe that listing of just potential ideas, even though a lot of them, I remember when the EMTs came to us with like 27 ideas, and we kind of said, well, these 8 might work, and I think we got 5 bills out of it. But it's important to start documenting that, and if we could get that.
Put it together in a document, put it together in a slideshow for us
Mr. Chairman, I'll do my best.
with music.
Yes.
However you want to put that together. That will be important for the future groups.
Yeah.
The other chairman and I won't be there to listen to them, but we'll cheer you on.
Thanks.
Thank you very much. Okay, looking down our list, we change a little bit of gear. We're going to go to the community colleges. If we have someone here about potential midwife programs. You thought we'd never call you up, didn't you? Welcome to Labor and Health. You know, someone told us last night when we talked about this committee and why we never see him in this committee, he said this is called the no-go committee. So thank you for coming. Go ahead.
Thank you, Mr. Chairman. I am Laurel Ballard. I am the Chief Academic and Student Services Officer with the Wyoming Community College Commission. And maybe I'll bring that closer so I can hear it over the speakers. There we go. I don't know that we have a lot to update you on from when Dr. Mortz was here at the last presentation, right? We know that we don't have midwife programs at any of the community colleges, so we would have to figure out how to create one, right? It would take curriculum. It'll take staffing at the colleges to be able to do that. It's a different set of skills than what we see in just the nursing. So we have that. We know that if we are looking to stand up a program, it can take as few as 12, but it typically is closer to 18, but we can fast track some things if we need to get a program up faster as well. Mr. Chairman, with that, I'm just going to stand for questions from here.
Very good. Questions? Go ahead, Representative.
Thank you, Chairman. Thank you, Ms. Ballard. How many of our junior colleges have nursing programs?
I believe all of the community colleges have nursing programs.
All, which is how many?
8, 7 to 8.
Okay. Any further questions? Go ahead, Representative Ward.
Thank you, Mr. Chairman. My daughter is involved in a nursing program at Central Wyoming. Yes, they have nursing programs, but I believe they stop at a 2-year because she has to transfer to a 4-year to get a BSN, for example. So correct me if I'm wrong.
That is correct, I believe so. I mean, they have they call the 2+2, right? Where you have the 2 years at the community college and then the 2 years at the university to get the bachelor's.
Chairman.
Thanks, Mr. Chairman. I'm wondering if there are research ways to check with the current, nursing students or people entering any of our 8 community colleges and saying, how many of you would be interested in taking, a doula course? I'm sure that's not what it's called, but it's a certification. I'm assuming that, I don't know what the curriculum is or how long it would take, but having even a class on maternity care. We have a whole program in early childhood development, whether this could be offered to, I guess my question is, how do we know what the demand might be? And are there ways to study through some type of qualitative or quantitative metrics, whether we could stand up a program and what the applicant load might be at one or more of our colleges?
Go ahead.
Mr. Chairman, Co-Chairman, I believe, yeah, we could certainly do that, right? We could certainly go and work with like our academic affairs VPs that are working in the presence, working on this to figure out what that would look like. I mean, that's when they go and create a new program. That's part of what they do, is look at what the student demand would look like, as well as what the industry demand, right? Like, what is it? How many jobs will we see out of that as well? So that's part of what they look at when they create new programs. So it's absolutely possible.
Has that ever happened from the legislative, I just say dictate? I mean, I remember this world and how it kind of organically comes from an industry or business. I can't remember that the legislature, maybe even the executive branch, has ever pushed. But if we did, what would that look like? Is it a friendly ask? Is it a formal letter from this committee to initiate, an investigation of the metrics? How help us help this program and what that would look like and what you might need either from the legislative or executive branch to go forth and investigate?
Mr. Chairman, I don't know that we have to have a formal request. I mean, we could certainly work on figuring that out and bringing the information back and work with the colleges to help us create that.
And while there are ears listening, the subgroup may consider putting that request forward, Ms. Bush. Look, she wasn't paying attention. This may be something that the subgroup wants to put forward, a question or a survey to the community colleges. Okay, further questions, Representative Ward?
Thank you, Mr. Chairman. I just want to add a note of clarification. Doulas are traditionally certified through private organizations like DONA, which used to stand for Doulas of North America, for example. And there are several private organizations that certify doulas. Now, traditionally, doulas have not been certified through college programs, but that's an interesting idea. Wouldn't you agree?
Mr. Chairman, that'd be certainly something interesting to look into.
Very good. And that may include a study of midwives as well. Okay, further questions, committee? Seeing none, thank you very much, Ms. Ballard.
Thank you, Mr. Chairman.
Okay, and that brings us up to Board of Nursing. Which brings up an interesting, while she's working her way up here, something that we really haven't talked about is the need for specialty nurses in OB. In our smaller hospitals, we have our nurses that rotate through. They do, OB, they do ER, they do a little of everything. And that's something we don't want to forget or overlook here, is that we don't just need OB to actually do the deliveries. We also need the nursing care to follow it up. But go ahead and introduce yourself and go ahead and tell us everything you know.
Thank you, Mr. Chairman. I'm Robin Cole. I'm the Practice and Education Consultant at the Wyoming State Board of Nursing. And we have provided today just our numbers for certified nurse midwives in the state of Wyoming. As of yesterday, we have 42 licensed or have privilege to practice in Wyoming. Of those 42, we have 19 that have Wyoming addresses. We don't collect workforce data, so we don't actually know that they are where they are working at. We only collect that every 2 years, so we don't have an accurate description of where they're actually working. But we wanted to provide that information for you today, and I can stand for any questions that you may have on certified nurse midwives.
Ask for questions, committee. Seeing none, this is called the postprandial. Oh, we got one.
Well, I have you. I'm just, complaints, how many do they go to the Board of Nursing if somebody complains about a midwife? I assume they go to the Board of Midwifery, but do you get anything tangentially, complaints, concerns, investigation requests, et cetera, in this realm? And do you hand those off or do you investigate?
Thank you for the question, Representative. We are certified nurse midwives are governed through the State Board of Nursing. There's also the Midwifery Board, and they govern those midwives. So they're two separate things. So if it's a certified nurse midwife, we do get those complaints and we investigate those and follow through with those, whatever, the outcome of that will be.
Go ahead.
And how many, say, in a year do you receive, if any?
I have only been at the State Board of Nursing for a year, and we have not had any on certified nurse midwives to my knowledge in the last year. I can gather more data for you on that and present it to the committee if you need.
Very good. Further questions, committee? And I know that, and you may be able to clarify it, and it hadn't been talked about a lot, the difference between a certified nurse midwife and just a midwife.
So I can speak to the certified nurse midwife, thank you, Mr. Chairman. I can speak to the certified nurse midwife education and licensure. Certified nurse midwives are advanced practice registered nurses, so they are going to be certified and licensed through a population and foci. So we have 6 foci that advanced practice registered nurses can go to, and certified nurse midwife is one of them. So they are advanced practice registered nurses. They get licensed, they go through a program, whatever that program may be. They vary, it can be a master's program, it can be a postmaster's certificate program, it can be a doctoral program, but they complete that accredited program. They sit for a board or a certification, and that certification, once they get that, that allows them to have the competency and apply for licensure through us at the State Board of Nursing. I can't speak to the process for midwives, they'll have to speak to that.
Perhaps somebody that follows will. Quick question to follow that up. Where is the closest certified nurse midwife program? I assume we don't have one here, or do we have one in Wyoming?
Thank you, Mr. Chairman. We do not have a program here in Wyoming, and I do not know where the closest one is, but I can provide that information for you.
Mr. Chairman?
Go ahead, Anna.
Mr. Chairman, they have programs in Utah, Montana, and Colorado.
Very good. Representative.
Thank you, Mr. Chairman. Of the 19 that are located in state of Wyoming, are they dispersed throughout the state? Or are they mostly located in, I would assume they're in the smaller towns, I would hope. Thank you.
Yes, thank you for the question, Mr. Chairman and Representative. We did provide a visual bar graph that shows where their resident is. So again, I don't know if they're currently practicing in those towns, but it's spread out across the state. Our highest are 3 in Cheyenne, 3 in Laramie, 2 in Rock Springs, 2 in Sheridan, and then 1 throughout. It kind of looks like this. Yes, thank you.
Very good. Further questions for the board?
If I could, Mr. Chairman, I also just wanted to say that our associate degree programs at the community colleges, they have an agreement with the university, so our ADN nurses can concurrently take classes for their BSN through the University of Wyoming and come out with a 4-year degree with that agreement, collaborative agreement in the state.
Very good. Okay, thank you very much.
Thank you.
Okay, moving down the list. Do we have anybody here from the Board of Midwifery? I can't say it, so hopefully you can understand it. Come on up. We got more than one seat, so come on up if there's more than one person to come up. Welcome to the friendliest committee in the legislature. Go ahead and introduce yourselves.
Hello, Mr. Chairman, members of committee. My name is Amy Borelli. I'm a licensed midwife. I live up in Worland. I'm also the chair of the Board of Midwifery here for the state of Wyoming.
Thank you, Mr. Chair. My name is Carlos Gomez. I'm the executive director for the Board of Midwifery.
So I guess we should talk a little bit about what the difference about midwives in the state of Wyoming are. Sorry. So in Wyoming, we have the certified nurse midwives, you just heard from the nursing board. We also license certified professional midwives. It's a totally different route of education. So the most basic way to explain it is I never went to nursing school. I went directly to midwifery school. Took me about 3 years, and then I took an exam similar to a board, but it's specifically midwifery, received my my CPM, the Certified Professional Midwifery, of Certified Professional Midwife, and then I applied for licensure with the state of Wyoming. So in Wyoming, for CPMs, you have to go to a certain school to be licensed. So throughout the country, there is a portfolio evaluation way of becoming a CPM, or there's an education way. So in Wyoming, we only recognize the education route. So everyone has to have gone to what we call a MEEC school. And then, as you said, doulas are kind of something totally different. They're not healthcare professionals in the sense that they do not provide medical care. They provide supportive care. So you can have a midwife and a doula at the same birth doing different things within their scopes.
Is there a national accrediting agency for the CPM, or is there?
Yeah, so we're credentialed by the North American Registry of Midwives. It's referred to as NARM for the midwives. So whether you do that portfolio process or an education process, we all take the same exam at the end of the day.
Okay, very good. Anything further? Oh, we had a question for you. Representative Ward.
Thank you, Mr. Chairman. I have probably several questions. The first, what is a MEECS school? Could you clarify that for the public?
Yes, so there is the Midwifery Education Accreditation Council, which accredits certain schools that certified professional midwives can go to. So there's a bunch of different schools. Some are accredited, some are not. The accreditation requires a certain standard of education. So any school which is MEEC accredited, you know somebody who went to that school had this minimum level of education compared to other ones. So.
Talk to me about births you've supported where you had to transport to the hospital and then you perhaps were treated less than politely at the hospital, and how we could fix that.
Go ahead.
So as a midwife here in Wyoming, I've been working here for 10 years. I have transferred to a lot of hospitals in the state. There's been really good experiences. There's been really poor experiences. And I do think that is one of the biggest things when it comes to maternal health outcomes. I've had transfers where I show up with records, try to give a report, and the doctor just walks right through me and doesn't even hear a word I have to say. Even though I can tell him, here's what's going on, here's what the problem is, here's why we're here, they're not interested. There's also times in Worland, which is where I live, the transfer process is amazing. The doctors have reached out to me. I have their cell phone numbers. I call them, I give report. It's a very smooth transfer of care. If they need to go to a further level of care, the doctor in town takes over, gets them to where they need to go. So there's a huge reception difference just depending on which hospital you go to and which doctor you go to.
Go ahead, Representative Ward.
Thank you, Mr. Chairman. Do you have any ideas? Does this need to be solved in the private sector? Do you have ideas that could be addressed legislatively?
I don't know if legislation would work as well, because I don't know if you can tell a doctor they have to be nice to the midwives. You know, I would love it if you could, but I think a lot of it is private. It took myself about 6 years to get the relationship that I have with my local hospital to the point where it's at. There's other hospitals that I'm just waiting for another doctor to come. But, you know, in the ideal world, we're all working for the same goal. Healthy mom, healthy baby at the end of the day. Ideally, their birth goes exactly how they envision it. There's no guarantees in birth. But it would work a lot better if the midwives have a problem at home, we can call up the doctor closest by, just like if the doctors have a problem they can't deal with, they can call up Billings or Denver or Salt Lake and they get a good reception. It would be ideal if we could do that same thing, get a good reception when we call and say, hey, we're having a problem at home. It's not safe at home anymore. We need to be at the next level of care. If we could get it, so it's kind of that same thing, going from home to hospital is just like going from hospital to a higher level of hospital.
I'm going to interject one question, one quick one here before you go, and that is, in your case, in the community where you first went into, how did you introduce yourself to the doctors, to the hospitals, what was your means of establishing your credentials or your means of doing things?
When I first got there, it was right after the Board of Midwifery was established. We started issuing licenses in 2012. I was licensed in 2014. So licensed midwives were still very new. In my community, there had been unlicensed midwives, because we didn't have a license, who didn't always have the best outcomes in transfers. So when it was, the hospital when I first got there was very resistant to me. So I reached out and they were pretty much like, we're gonna pretend, we just wanna pretend you're not there. And over the years, we got new doctors who had worked in larger areas where there were more midwives that they saw more. So they knew, like, we don't all just show up with nothing, like we're actually have the equipment and stuff. So it became a lot, as new doctors came in, I spoke to them more and we formed relationships. The current doctor we have in Worland right now has been there, I want to say about 4 years now. And she came from Washington State, where I think they do about 5% of the births in that state are at home or in birth centers. So she was more exposed to midwives. Where I live, I'm the only midwife for almost 100 miles. So their exposures to midwives is me, myself, and I. You know, I've been working on it. And like I said, right now, the transfer relationship I have in Worland, I'd say is the best in the state, so.
Okay, Representative Ward.
Thank you, Mr. Chairman. Are you allowed to go into the OR if that's the operating room, should that a C-section become necessary?
Generally, no. I have gone in if a support person, such as a husband, father, the baby is not available. I'll go as that support person, but as a provider, no, I'm not.
Okay. Follow-up question.
Would it be helpful if you were?
In some cases, I think it would. My training is not in the operating room. So in some ways I could see sometimes it might be more of a hindrance just because that's not where I work. But in other cases where moms are like, I just met this doctor an hour ago, I don't know who they are. The only person I know here other than my family is my midwife, who I've been working with 9 months. I think it could be helpful.
Another follow-up, go ahead.
Thank you,
Representative
Mr. Chairman. Speaking as a mom who became a doula because I was angry at how my 2 births went. I have had 2 C-sections. It was frightening, would be frightening to me if I had a midwife as a caregiver and then she or he can't accompany me in the OR. So speaking from the patient's perspective, but also I think the midwife ought to be given that respect. Now, it doesn't mean you're going to do operations in the OR, but you're there to support your patient. That's your patient. So do you see it valuable mandating that, or you see it growing organically?
I would hope it would grow organically. I do know in other states, so before I came here, I lived outside of Philadelphia. So I've worked in Pennsylvania, New Jersey, Delaware as well. In a lot of states and a lot of hospitals, doulas and support, like extra support people outside of the family can go into the operating room. Sometimes they need to take a class for that specific hospital. But the outcomes do seem to be better when the moms have people who they know. Because a lot of times when you're transferring from home to hospital, the moms have never met these people before. I might know the doctor, but the moms have never seen the doctor before. And it's a scary experience, like you said, when you're planning to have your baby in a tub at home and then you're in an operating room with a million strangers. It's a little bit of a change in a lot of things. So I do think it would be very helpful Mandates would be great. I mean, as a midwife, I would love everybody being like, hey, respect the midwives, because it makes my life a little bit easier. But I'm also a realist. I don't know if they would be listened to. I mean, right now we tell hospitals, you know, midwives are healthcare providers in the state of Wyoming. They should be able to order labs at your labs or order ultrasounds. And there are places that are like, that's nice, we're not doing that. So.
One further question. I don't know if anybody else had. Go ahead. We'll get mine last. Go ahead, Representative Horlock.
Thank you, Mr. Chairman. I'm curious, over the course of your time, career here in Wyoming, and then curious about other places as well, but have you seen a trend, growing trend in the state toward using midwives? What does that look like? And do you see that trend continuing to rise? What's your, I guess, a guess on where this goes from here?
So yes, I have seen more births over the 10 years I've been here. The Board of Vital Statistics actually publishes planned home births in Wyoming. Right now, we're running a little over 2%. I want to say about 2.3 to 2.4% of all the births in the state of Wyoming are attended by home birth midwives. In Wyoming, the certified professional midwives, the licensed midwives like myself, are the primary home birth providers. There's also 2 certified nurse midwives who attend home births. When I started, I think we were below 1%. A couple around 2020, when COVID started and things kind of went a little sideways in the healthcare segment, I myself did between 50 and 60 births in a calendar year. It's a lot of births, it's a lot of being on call. Part of the problem here in Wyoming is we don't have a lot of midwives. It's just like with the doctors. It's a hard sell sometimes to get people to come to Wyoming when they're like, it's minus how many degrees? You know, like I've been trying to get friends from other parts of the country to consider Wyoming because I'm like, our laws are great. Like we need more care providers, and the snow and the distance and stuff sometimes scares off the ones from the big cities. But we are doing a lot more. I think the total births, it was in 2022 were the last statistics that were published, but I want to say home birth midwives did around 190 births, and there's only 17 of us licensed that are currently practicing in the state.
Very good. Follow up, go ahead.
Thank you, Mr. Chairman. And then I guess, how are you paid? Or is it mostly that people come to you and you have you charge them directly? Do you bill insurance, or can you be paid through Medicare or any state services federally? Just how are you paid for services?
So I'm either paid by cash, by commercial insurance, or the health share plans. I also am a Medicaid provider, so I can bill Medicaid for the services I provide. When Medicaid pays the home birth midwives, they're not paying a facility fee. So if somebody delivers at home, Medicaid pays the provider who was there, but they're not paying that extra hospital fee because there's not a hospital. But insurance will also pay. Most insurance plans, Blue Cross Blue Shield, Mountain Health, will pay licensed midwives depending on the individual's plan. And then some people pay cash.
Okay, now it's time for my final question. And that question is, and you can speak for your own profession, but nurse midwives, are they required to have NRP, acronym, newborn resuscitation? Are you required across the board to have that?
Yes, all midwives in the state of Wyoming, I'm assuming so for the nurse midwives. But all the licensed midwives, we are required as part of our license, we renew every 2 years, and you need to send in a new, a current neonatal resuscitation and a current CPR certification.
Very good, thank you. Further questions, committee? Anything further to tell us? You've been awful quiet, sir.
Thank you, Mr. Chair. I was here to be some backup and brought the rules and statute just in case there was some very creative questions that the committee wanted to throw our way.
Any creative questions, committee?
Oh, I did it.
Okay, you're off the hook. Thank you very much for
Thank you, Mr. Chair.
presenting. Okay. Okay, moving down the line. And really, anybody here in the public will have a time to ask questions, come up and present to us after we're done with this whole section. So next, I see Wyoming Business Council on the agenda. Welcome. It's good to see happy, smiling faces. Go ahead. Introduce yourselves and present to the committee.
Didn't push it hard enough. Hello. All right. Hi, Mr. Chairman. I'm Kristen Fong. I'm with the Wyoming Business Council. I'm their Northwest Regional Director, which means I'm based in Cody. So I got to drive down with these fine folks from Washakie County, I guess, as well. So I'm also involved in a special project that the Business Council is working on that's focused on workforce issues and specifically childcare as a workforce issue and as a business issue. And so that is why Roxanne is here with me as well today, Roxanne O'Connor with the Department of Family Services. So, thanks for having me. All right, so I think you all just got your little slide packet there, and I wanted to just pull together a summary of what I wanted to share with you today. And, you know, this is actually representative of a project that the Business Council first partnered with the Growth Lab from Harvard's Kennedy School on. And it is, you know, it's back hearkening to our mission of creating new opportunities for current and future generations, AKA the children.
Quick question.
Yes.
Is this available for Senator Barlow and Senator Hutchins to see as well? Okay, go ahead, proceed.
Okay, thank you. Yeah, so hopefully they will have access to that there. It sounds like a yes. Okay. So, you know, that's our mission, right, is to take care of future generations of Wyomingites as well. And so I'm first and foremost, I mean, I guess I gave you my job title already, but I'm also primarily a wife and a mother and a working mother with 2 young kiddos. And so there's been times at the Business Council and even prior to that where that it was a challenge, right? Finding inconsistent or inaccessible or really unaffordable childcare for my 2 kids. So, you know, I care deeply for my children's sake and for my own, you know, life here in Wyoming that to have a future in Wyoming, you will need to find a job and support yourself. And if you can't find childcare, then you might not be able to find a job. So my task today is to bring to your attention the issue from a business perspective, right? So our colleagues and partners at the Growth Lab analyzed and interpreted data that illustrates clearly the lack of supply of childcare is really exacerbating the state's workforce needs. We're already all likely aware of that issue here. And we're experiencing in the state of Wyoming the tightest labor market that we've seen in this century. So in fact, there are more than 2 job openings for every unemployed person in the state. So really, to outline what I wanted to share, insufficient access to affordable, reliable, and high-quality childcare is negatively impacting the workforce availability. All right, we can jump to the next slide, please. Oh, thank you. So good. So the main points that I shared in the overview that was in your packet, which goes a little bit more in depth than this presentation today, is that the childcare market in Wyoming is severely supply constrained. So we've got a gap of 28% in Wyoming overall, and that gap leaves about 5,000 children with both parents in the workforce without access to childcare. So we're essentially considered a childcare desert, right? Certain parts of the state are faring better than others, but Wyoming itself is a childcare desert. So there's probably about 10,000 individuals who would like to join the workforce that can't because of childcare. So, you know, families have been forced to pursue second best options, maybe staying outside of the labor force entirely. Really, it's just exacerbating the workforce issues that we're facing. Previous policy attention in Wyoming has been focused on demand side of the problem. So especially through subsidies to families directly to help them afford childcare. So the current efforts that this presentation kind of represents is that it's refocusing on what prevents supply from growing, right? We know the demand is there, why is supply not meeting it? So statewide policies and initiatives could substantially increase the childcare supply in the market with two distinct kind of channels or two different directions that we could look at more carefully. And childcare centers as an option, especially prevalent or maybe more viable in larger population areas. And then home-based providers, which work especially well in smaller markets, smaller, more rural communities, just based on, population size. So there's also significant room to explore innovations across community assets, right? Different kinds of initiatives that might help communities better leverage community centers, say, or community-based childcare solutions. But today I wanted to kind of drill down a little bit on both the home-based care providers and childcare centers specifically, because there's several initiatives that are already underway and we're making some really, really cool progress on. Next up, if we can, thank you. All right, so in your packet, you probably have received this diagram that outlines the potential actions available to us or the proposed solutions that we've narrowed down. So it's a rather dense slide, and it was authored by our partners over at the Growth Lab in conjunction with several other partners, one of which is sitting next to me here. And what you're seeing is the result of data analysis and really significant consistent partnerships and communication with several colleagues across the state and colleagues represented as different agencies and organizations, nonprofits, and really great conversations with care providers themselves as well as part of that data collection. So our partners include the Department of Family Services, we've got Workforce Services, and especially Wyoming Quality Counts, which participates in our bi-weekly calls. The Governor's Office, the Department of Education, even the Wyoming Department of Corrections, who is struggling with access to childcare as a workforce issue. Wyoming Department of Health's Maternal and Child Health Division, Wyoming Women's Foundation, Wyoming After School Alliance, Climb Wyoming, and many, many others. So one, I just want to take a moment to celebrate, some of them are in the room with us here, but the cooperation that this project has achieved through these partnerships is really incredible. I've worked for the state of Wyoming for just over 3 years now, but so I'm not sure, what the past really looked like, but the fact that all of these state agencies are collaborating and, banding together to identify what are the solutions that we can really tackle and drill down on as a team is pretty cool. So there's a coalition of people here that we're willing to work with the businesses to act on many of the solutions here. So, so the next two slides really are going to dive into home-based, like I said, what that looks like as a business model and what the impacts of expanding that opportunity in the state could have. And then after that, we'll talk about centers. So what is a home-based provider? Home-based providers offer childcare in their homes within regulated limits. So they're a preferred option for many families and have viability in markets, smaller markets, that maybe are not large enough to sustain a childcare center. So home-based childcare is of special importance in this study because of its prevalence in the rural areas, and it's really an effective, actually very profitable business in many areas of the state. So the home-based model boasts strong take-home profitability and has natural incentives that go along with that operating out of your home, including tax write-off benefits for business expenses such as rent and mortgage payments, et cetera. The regulatory burden is actually relatively light, especially as compared to a childcare center as well. But there are, obviously, and certainly necessary regulatory needs. So the biggest area of support that we've identified for home-based centers is business support services and outreach for home-based providers themselves. So some of this activity is already happening with our partners at Department of Family Services. So their agents work already on a regional basis and serve as that first point of contact for many of the potential providers that are looking to get licensed, or also as regional resource centers. So as you're working on setting up your in-home childcare facility, they'll walk you through that process. So just what we have identified as a need is closing that information gap and reaching out to current home-based providers to kind of communicate and better almost foster that growth with them in terms of what are your business needs, where are your challenges, and helping them through that, the process of running a business out of their home. So what we've seen though, over the past several years is that home-based care centers, I'm not gonna call them a center because that's confusing, but a home-based provider it's on the decline. So although they have these more attractive cost structures, there's been a net loss in the number of home-based provider every year since 2019, and more providers are basically closing than opening. So in the last, maybe 14 months-ish, we've had just 23 new home-based providers opening. And since they're typically owner-operated, some exit is normal, retirement, et cetera. But really what we have identified as a group and what a study through DFS provided us was that they're seeing this business as a great opportunity, but that it does require a really specific skill set and a desired lifestyle. So, do any of you have kids? It's a lot.
We have a question for you.
Sure, yes,
I have
thank
one
you.
in relation to Representative Yin and others brought a bill on residential childcare. We didn't see, I guess, a spike. It wouldn't affect July 1st, is that correct? And so when you said last month we only had 23, any noticeable spike for an immediate based on having in-home daycare?
I think that was, it was a much needed, thank you. I think it was definitely much needed. I think you can probably speak to that better.
I guess the question is, did you see any noticeable spike immediately or any increase, or how many people reached out? Any excitement around it? We were excited on this side of the table, but.
Go ahead.
Thank you, Mr. Chairman. Representative, again, Roxanne O'Connor, Support Services Senior Administrator for Department of Family Services. I don't know, that's a fairly new bill, one that I think is going to be a little bit tricky to measure. I want to make sure you're referring to the covenants bill, correct?
Yep.
Okay. And so I'm not sure that we can tie any sort of interest right back to the bill right now. But what I can tell you is that anecdotally, we are seeing an uptick in interest in applications, and that's relatively new, right? And so, timing, right, could speak to that a little bit. But what we're seeing is, like Kristen said, really our licensor is working very hard to really be community representatives, being really approachable when there's interest about licensing and providing a lot of technical assistance around that. And then we celebrate when we start to see that interest and those applications go through, and we start to see new providers opening.
Nice to know when things are working.
Thank you. That's good. Go ahead.
Thank you, Chairman, for the question. So existing providers or new as well, it's really clear that they see it as a great opportunity. And certainly the proposed initiatives here that I'm sharing with you really are just about lowering barriers to entry and supporting existing operations so that we can reduce the number of closures and then simultaneously see more open. So small business support was indicated as a major need for many of these home-based providers. And, you know, they struggle with business management challenges, most likely that can be eased with ongoing small business training and support. So eCares and LMS for training are both currently being worked on with Department of Family Services. So basically, parents and guardians don't always know about home-based providers as an option. And so eCares will be this central portal for providers to advertise their business that's it's already in development and being worked on. And initiatives like this really are win-wins for both parents that are seeking childcare and the providers that are providing it. The peer-to-peer to support is another aspect of this that was indicated as a major need. Really, it's just at the end of a long day caring for your kiddo, sometimes you need to talk to an adult and have those conversations professionally as well, and say, you know, here's what I'm learning in my training, here's how I handled this situation. And I think Roxanne can probably elaborate on that if she would like to. But, okay. The other thing that we have worked on together is startup grant possibilities. So we're proposing a braided partnership for small startup grant pilot program, excuse me. So basically startup small grants that would help offset small but meaningful startup costs. So although home-based providers, like we said, have less maybe upfront capital investment because of the lower regulatory requirements, there's nonetheless, it's still a barrier to maybe their entry. And so if we can ease that for them by offering a startup grant, that would be a great way for them to enter the care market. So say a relatively small fund of $200,000 could provide $2,000 to 100 new providers, which would amount to 1,000 new slots if each provider was able to open 10 seats in their childcare facility. So this alone would boost license capacity by nearly 5% across the state. So definitely a good option to consider, and one that is collaborative in its nature. If we're sharing funds across agencies and working together to you know, pool our resources, say. Did you want to jump in? Are you good?
Mr. Chairman, I just kind of wanted to add that I think to really drive home what Kristen is talking about in the collaborative process of this, and bringing together such amazing individuals from such a diverse array of state entities, nonprofit entities, to really have a unified goal and mission and say, hey, we could put a little bit towards this, if you could put a little bit towards this, and then we can make something really powerful happen. It's really very exciting. There's a lot of enthusiasm around it, and quite frankly, is a dream of mine since I've been working in childcare for about 7 years. And so I think that just kind of shows really the significance of just bringing people together and doing some idea sharing and some solutioning, and then having that willingness to really come together and partner.
Thank you, Chairman. Thanks, Roxanne. So the other final aspect of home-based childcare providers that might make an impact as we look ahead is some regulation and ratio review work that Department of Family Services is already undertaking. You know, there's sometimes those zoning restrictions, right? And so here's where that House Bill 126 it was. I have it in my notes now that I'm looking later. That's the one that it isn't making a huge impact, right? And so we're going to use those survey results to inform potential rules change as needed. So again, just that collaboration between all of these partners is helping our progress move forward. So let's turn the page here, go to center-based care. And as I already shared with you, centers provide a higher number of slots. They also employ more individuals to provide the care, and they represent roughly 85% of current licensed childcare slots in the state. So difficulty that centers are facing include that they're often operating below licensed capacity, even though they have wait lists. They have difficulty hiring and retaining workforce. You know, it's a really big difficult, challenging job sometimes, even if you love children. And so, you know, staffing challenges in the childcare industry is really well documented. So I don't think I really need to elaborate on that, but staffing really is one of the top constraints that centers are sharing with us. So generally, staffing costs exceed revenues, and this is not due to individual high salaries by any means. So on the contrary, US average wage for a childcare worker is $600 per week. That amounts to about $31,000 per year. So average wage for childcare workers in Wyoming is actually even lower than that, it looks like. And they've seen wages kind of stagnate over time. So we haven't really seen a large increase in childcare workers' wages in relation to cost of living since 2017. So that is probably what's most indicative of low profitability in centers and inability to pay those competitive wages. So in comparison to all workers in Wyoming, childcare workers are also approximately twice as likely to be living in poverty than other workers. So many of them have certifications or higher education degrees and could potentially earn much more in a K through 12 environment, elementary environment, than an early childhood educator might. And so that's really interesting, right? A lot of workers will go and obtain a further education. They love working with kids. They want to learn more about how kids learn. And then they invest in that education, but then leave the early childhood workforce to join elementary ed. So, you know, there's definitely some more information out there about what benefits could be offered to retain childcare workforce. And that's something I think in the future I'd like to return to you all to deliver if that's, you know, appealing and interesting. But for now, I think some of the highest impact solutions really are, you know, providing some kind of healthcare subsidy or a childcare subsidy for childcare workers. So childcare subsidies for early childhood education workers or childcare providers. Really, it's actually parents of young children that tend to be in that workforce, tend to be the workforce. They already have the young child, and then they like working with children, and so they are employed by a childcare center. So they're, you know, nonetheless, still a really high turnover industry. So childcare workers in as a licensed provider could be permitted to apply for state-provided childcare subsidy, regardless of family income. So this kind of program would encourage parents of young children that are possibly currently out of the workforce to contribute to the Wyoming economy while also providing childcare needs for other parents to also join the workforce. So that's something that I think is an underutilized tool at the moment and could be improved upon, and messaging around that option could be shared.
Mr. Chairman, if I can add just a note to the child care assistance recommendation. As a committee or as a group, we're kind of looking at a phased approach to that recommendation. Right now, just doing kind of a back of the napkin calculation, it's likely that most child care staff qualify for child care assistance under our current eligibility standards. It's a matter of making sure that they're aware of that program to be able to offset, you know, any costs that they have from a child care perspective as well, so that they can then go and care for other children and support the workforce. So right now, it's making sure that we take kind of a slow approach to this, making sure that the information is out there before we make any substantial changes to eligibility requirements or block grant funding or anything like that, but just to say, hey, this is available. If you're eligible, make sure that you know of this option, and then kind of seeing where the data takes us after we do that.
Thank you, Roxanne. Thank you, Chairman. The next option that we have in front of you all is the transferability of background checks. So delays in processing federal background checks are really onerous for hiring staff. Each center is kind of specific in its process and applies individually for that applicant for the position. And so although the Department of Family Services certainly can't resolve a federal delay, they are already taking steps to allow credentials to apply across all centers in the state. So this would mean that workers could easily switch providers, including acting as like a substitute or what you would call a rover, to fill as like in case of a staffing emergency, right? I think we probably experienced a little bit of alarming COVID pandemic. People are getting sick. People can't come into work. We can't care for your child. But we also then don't have a readily available substitute, right? So, but this is an ongoing problem, and it's one that in conversations, even anecdotally, with different childcare providers around the state, they've said, oh, that would be immensely helpful. That would solve so many of our staffing problems. If one calls out sick, we don't have to call, the parents of an entire classroom and close down that classroom of whatever 10 or 12 kids, just because one person calls out sick. You can bring in that substitute that's, universally vetted and say, we can still remain open. And so then the parents of all of those 10 or 12 children can continue to work. So that's already underway. Those improvements are already happening through the Department of Family Services. So in summary, childcare supply really is a solvable challenge. Isn't that worth celebrating? So we also are not coming today with any kind of large fiscal ask. Really what we're doing is just sharing with you the progress that this group has made, celebrating some of that momentum that has been gained over the partnerships and the course of this research with the Growth Lab and with each other. And again, we're going to continue to plug away on this. And I am available and happy to answer any questions you might have.
Any questions for Kristen? Question, go ahead, Representative Clausen.
Thank you, Mr. Chairman. Thank you guys for being here. Just saw you yesterday in Casper, so here we are.
Yeah.
I know Casper has the associate's degree, arts in early childhood education. It's the only junior college in Wyoming that has that. Do you have any information on how successful that program's been, or how many students there are using that program?
Go ahead.
Mr. Chairman. Representative Clausen, yes, good to see you again today. I don't have information specifically on that program. What I do know is that this group is really looking at, from a capacity building perspective, how do we use those types of community college programs, not only from an early care and education perspective, but also from a business perspective. So how can we get some curriculum in place, some workshops in place in different communities through the colleges to be able to support home providers and say, here's the tax deductions that you're eligible for, and here's how you account for those, right? And so there's been a lot of discussion between our group of, we have this infrastructure in place, and it's in different communities, so how do we use that for providers? I'm trying to think of who we'd connect with. I can try and connect with the Community College Commission or somebody to see if we can get you some numbers on that program.
Ms. Ballard shaking her head. Further questions, Representative.
Thank you, Mr. Chairman. What's required to start or to be a home-based child care provider? Is there a licensure? What are they required to do? Is there a certification process? Is there yearly reviews? Just curious about all that.
Go ahead.
Mr. Chairman. Representative Hornak, yes, so home-based providers are our smallest providers, and those providers can care for up to 10 children in their home with just one person, or up to 15 children in their home with 2 staff. And they do have licensing requirements, so they're required to be licensed under Wyoming Statute 144101. And that licensure includes your health and safety requirements. So a fire inspection, sanitation inspection, ensuring that you have enough square footage, playground requirements, food preparation, those types of licensure requirements. And then there is an annual renewal of their license.
For a follow-up, go ahead, Representative Warnock.
Another question on your slide. You said that very first slide, an estimated 10,000 Wyomingites may be out of the workforce due to lack of childcare. Curious how you arrive at that number, and then is it possible that there might be a segment of that 10,000 that just doesn't want to be in the workforce, where maybe the mom wants to stay home with the kids or something? So curious how you arrive at that, that number, which seems to be a little bit, I don't know, like a shocker kind of number for this slide presentation.
Go ahead.
Thank you, Chairman and Representative. Thank you for that question. It's a really good question. And, you know, we have a set of data that the Growth Lab has compiled and analyzed for us, and that is how we came to that number. I can share with you absolutely that full report if it is something you want to dig into a little deeper. But yes, you're absolutely right. There are probably likely lots of families that would prefer to have a stay-at-home parent versus both parents working. But, you know, I think we're looking at this number as evidence of a need that we see, and whether or not the families take advantage of a childcare spot is up to them. But, you know, we're trying to meet the supply side as well. And so if there just aren't enough spots available for families that do want them, you can't really necessarily make an informed decision, I guess. Yeah. That's more my opinion than fact, I guess, that last sentence there. But I think it's an interesting question, and it's one that we did take into consideration, right? Yeah, absolutely.
Very good. Further questions, committee? Go ahead.
Thank you, Mr. Chairman. I'm glad to see that DFS is doing a review of the ratios and regulations. And I'm glad to see there was a spike. I think the free market's gonna catch up to it if we work together. And I hope there's no more childless deserts out there.
Wouldn't you agree?
Wouldn't you agree?
Further questions? Thank you very much.
Yeah, great questions. Thank you, Chairman.
Committee, we've been sitting here for 2 hours. I know we're near the end of the list, but we're gonna take a 15-minute break. I sense the need to stretch legs, go to the bathroom, et cetera. So we will see you back here at 3:45. We'll finish up. are we ready?
You hand this off.
Okay. It's amazing how quiet this room gets with a gavel, isn't it? I should do that more often. Okay, committee, that brings us back to our little final agenda for the day. I just have to find it on my sheet here. Wonder School, right? Could you say that on the mic? No. He just sang it. That was good. Welcome to the hot chairs. And I think we've got a handout from you. So go ahead and introduce yourselves and tell us all about the handout and Wonder School.
Thank you, Mr. Chair. I'm Devin Veman. I am a representative for Wonder School. Shelley Duncan is joining us on Zoom. There she is as well. And this is Emily Walton. You got to meet her via Zoom at your last committee meeting, and it was proposed that she come back, give you a brief presentation, and tell you what Wonder School can do for Wyoming.
Thank you so much. It's good to be here. Thank you, chairs. Emily Walton is my name. I'm with Wonder School. We'll jump in here. I'll try to make this pretty fast because I do not want to be between you and the end of the day any more than I have to right now. And happy to take your questions throughout or at the end, whichever works for your committee. So I'm not going to read these slides. You don't need me to do that. Let's skip ahead 2 slides, I think, at this point. We'll go to meaningful impact.
Okay, that's good, as long as you explain them real well to the people online.
I'm happy to do that, yes. And we can email this out to other folks too if needed. Okay, so meaningful impact. What I want you to take from this slide is our main goal is supporting small businesses. And we've already heard a little bit about this today, but those in-home care businesses specifically, going in and giving them the support they need to get up and going in a state and then to keep going. We stick with them for 2 years with our program. And the overall theme of this also is we know that these businesses can be profitable with the right support. It is a little bit tough to get up and going, but we know with that support that they can be profitable and really give people in a community a tool that they can use for their children and also help people who are running these in-home care businesses some wealth, frankly, to support their families. Next slide. So this is all of the work that we do. This is all the, I should say, the offerings that we have across the country. I'm going to focus on 2 today, the new childcare program creation and then the substitute teacher portal service. And happy to talk about any of these others if you have questions about them, but I just want to focus on these 2 today. Next slide, and state partnerships. And this is just an overview so you understand, we're not a super old company. We've been around since 2016, but we have quite a bit of experience now working in a bunch of different states across the country. So you can see here in 6 of these states, 7 of these states, we've done that new program creation. And then in Mississippi specifically, we've done that substitute teacher pool and had a lot of success there. Okay, next slide. So the substitute pool. How this works is we go in and we recruit people in a community to join our pool to sign up and deliver substitute services in their community. Now, you heard in the previous presentation from the Wyoming Business Council, they mentioned that idea of having a portable background check or a background check that wasn't just dependent on one center. That's also a very important part of this same tool, right? If you've got someone who's already background checked, you want to make sure that that can be portable across different providers who need that care and isn't just stick with one center. And the other thing that's been really exciting about Subpool as we've launched this in 1 state is seeing how we can grow that pool by taking the folks who've signed up to say, I want to do this work, I want to do this, gig economy work, I want to jump in and provide some of this care. And then we take that group of folks and recruit from there to see if there are people who want to become full-time teachers in that early childhood care area, because we know that's also a need in a state. And then we've been able to take some of those teachers and say, do you want to start an in-home care business? So we're really trying to make sure that wherever we're going in a state, whatever level, we're able to take that and grow it from there. So our substitute pool, I'm going to go to the next slide. This is about our case study in Mississippi. We jumped in here and started to deploy our product and did a bunch of recruitment, background checks, training, onboarding, and then made sure that we could provide that reimbursement for the people who were going in and giving employment to those teachers, and got a lot of providers and substitute teachers signed up pretty quickly. And that's been a very successful pilot. I'm happy to send you more information about it if you're interested in learning more exactly about that pilot. But what we saw and what we're able to estimate is with an investment on that platform, they're able to bring back just enormous returns because you can really go in and see, right? If you've got in this state, one provider's ill, that means 10 kids are home for the day. That means 10 people. I mean, you could even calculate it pretty modestly. Let's say 7 people that mean that day aren't able to go to work. That really does have an economic downfall from that. That's not a great outcome from having one person be sick for a day. So if you can jump in and really quickly fill that slot to provide that substitute, that can make a big difference in a community. Okay, let's go to the next slide. So I want to talk a little bit about our new program creation. We talked about this last time just a little bit. I wanted to touch on it again. So this program, we go into communities, and this is not a passive program. We're not waiting for folks to come to us and say, oh, I would like a little bit of help to start a new childcare business. We're out in communities actively recruiting people, putting them into a 8 to 12-week program, depending on the state's needs, and then helping them get through that licensing process, helping them get through that, there's those site visits or those health visits that they have to get through, and then helping them design their program in a way that they can accept children and become profitable quickly, because we know that most of these folks, it's not like they've got $200,000 sitting in a bank account, just living off of while they build their business, right? This is month to month. They need to bring that profit in very quickly. So help train them and get them up and doing that. And so if you'll see at the bottom here, we just did a sample proposal. What if we came in and just created 10 new childcare programs? You can see pretty quickly, you've got 10 new entrepreneurs. Sometimes it's 20 part-time staff. I think it's a modest estimate to say 75 parents can return to the workforce. And then you can see there that $14 to $29 million in annual economic impact. And that's just with, let's see, so that's with a really pretty modest investment to get those 10 new programs up and going. And so that's the stuff we love to do across the country. We go in and build those and try to get those folks up and going. And what we also do, I'll mention, is we stick with those providers for 2 years, right? It's not enough to just train them up and say, good luck. We stick with them, make sure that they have individual one-on-one support as they go through. I also want to mention, this is a great option for rural communities. This was already mentioned in the program before this in the presentation, but this is something, I grew up in a very rural community. I know my parents would not have enjoyed, driving into town 40 minutes to drop me off at a daycare center, but having the neighbor, provide care in her home was much more appealing. Okay, those are my 2 presentations on the new supply and then on the subpool. These next few slides, I'm not going to go through every single one, but we can just, roll through them. And I just want to show you what it looks like from each perspective on our platform for all of these different, there's all these different entities that interact with childcare in a state. You've got the government, of course, right? You guys need data. You need to be able to show that the work you're doing and the things you're funding are bringing back the thing you need in the state. Parents, the CCR&Rs, employers, providers, and teachers. And so this is how our entire platform connects together. I'm not here to necessarily sell you our whole platform right now, but I do want you to see what it would look like and how that all does connect for people. And we can, of course, connect into other platforms. I'm going to just roll forward. This is the government slide. Thank you for running the slides. And then the teachers, how they use it on their end. The next one is the providers, how they're able to start their businesses, run their billing, communicate with teachers, communicate with parents. Parents can go in and pay their fees on here. They can monitor children. Employers are able to participate by matching up if they choose to jump in and match up their employees with the childcare that they need. The CCR&R is able to pull the data. And that is the end of my presentation. I'm happy to take any questions. Thank you for your time.
Questions, committee? That was very fast. Do we have time to formulate questions? Senator Clausen looks like he's got something on his mind. Go ahead.
Thank you, Mr. Chairman. So just the thought of wrapping my mind around this. So the state of Wyoming would get in a contract with your business to help set this up through Wyoming versus you go out to individuals in the community and say, here's our program, and they do it themselves. So what are the options here of getting the program off the ground?
Yeah, Mr. Chair.
ahead.
Thank you, Representative. We don't, the situation we find ourselves in is with folks who have the aptitude to start a new childcare business because they have experience in childcare, they've got the willingness to do that. They don't necessarily have that business training. And so I have not seen in states a lot of successes of going out and finding folks and saying, you know, for several thousand dollars, we could train you, stick with you for 2 years. That would be a business investment on your part. And then, you know, you would hopefully be able to pay that as we go and then train them to keep that business going. So the way that it has worked is more like a small business association where people say, okay, the government says this is worth it for us to jump in, fund some small business training, stick with these folks for a couple years, and make sure that they stay in business. And then we see some returns to the state on that. So I would say think of it like a small business training center with extra help because it's childcare. I suppose it's possible that we could find some providers, some future providers who would say, well, I'm already taking quite a bit of risk to take time out of work to train, to get my house prepared, to bring a bunch of children into it, you know, to go through licensing, but sure, maybe I could scrape together some funds to do this as well. I would say that's probably such a high barrier, it's unlikely they would do it because it's already hard to do the licensing and to, you know, get your house ready, go through that. So it's a fair question. I haven't seen it work very well. Thank you.
Further questions, committee? Representative Warnock.
Thank you, Mr. Chairman. I'm curious doing something like this in the state, what would you anticipate being our startup cost for the state?
Mr. Chair, thank you, Representative. So for the new supply, right? So if we go in and we find one person, put them through the whole training, right? It's on us to find the people, get them through the training. We have people who drop out, and that's on us to go find more people. So for one of those that serves those 10 children, that's $30,000. So if we were to do 10 of those, 300,000, and I know you can multiply from there. So that's that basic cost. And then on the substitute pool, to serve, I think what we came up with as a pilot to serve about 3,000 slots would be 500,000. And then it would be, we would, as the years go on, we would stay in that same range, but then add on children. So the first year is it's a pretty, I would say it's a startup cost to get everything up and going, get people onto it. And then once you've done that, we try to amortize the cost as you go on. Happy to give you a more formal, you know, information and proposal on it, but that's the basic outlines. And I can give you I'm sorry, go on.
Follow-up, Representative Warnock.
Thank you, Mr. Chairman. I'm curious if you've looked into other ways of doing this, like the legislature has given, oh boy, 50-some million dollars to the governor on his Wyoming Innovative Partnership Program. That supports entrepreneurs and various things. I'm curious if you've looked into other ways to do this, other funding mechanisms.
Mr. Chairman?
Go ahead.
Yes, Mr. Chair, I was just going to say, I think Shelley raised her hand to answer just this question.
We have two hands up now. We're ready to go there. Shelley.
Thank you, Mr. Chairman. Actually, we have talked to different, the Wyoming Business Council, several other entities, and one of the barriers to a lot of those is they require infrastructure. They require a building, they require something like that in order to do some of this. So to do a pilot for multiple seats is kind of tricky because some of the Wyoming Business Council grants, now granted, they've changed some of their rules, was more of a municipal infrastructure kind of model versus being able to model something like this for individuals. And Emily does have some data and information that she can provide for you guys about other states doing a tri-share. So you have like Nevada, for example, they have the Urban League. So the government provides some funds. The Urban League is a nonprofit, and so some nonprofits, and so they share between the the groups and they work through that. So there's several different models. We're also looking at, we have some potential pilots, the one that she was talking about for Fremont County. We were talking about 10 potentials, and then the different nonprofits be able to apply for CSBG grants and other grants to have assistance. So we've been looking at all of that, but basically a statewide help like what Wyoming Business Council and DFS just suggested of some small grants to help these guys, entrepreneurs. And the last thing I wanted to just point out and reiterate is that what Wonder School does is they provide actually business software, applications, a website, Facebook assistance, advertising, a whole business model. Plus, they also help with the learning. They help with the education, curriculum, help them get their house prepared, hold their hand through the licensing process, and then they stay with them for the 2 years to make sure they're successful. So they did have some incredible numbers during COVID, where 60% of theirs survived through COVID, whereas a large portion of other providers closed down during COVID. So that's all I had to say.
No, you got one more thing to say. You forgot to introduce yourself, Shelley. We know who you
Oh
are.
my goodness, so sorry. Shelley Duncan, representing Wonder School.
Thank you. For the record, any questions of Shelley? Seeing none, okay, I believe Senator Hutchings had a hand up. Is it still up? It is. Go ahead, Senator.
Mr. Chair, thank you. I did. And I've decided maybe to hold back on some of them, but what I gather looking at this online, it's all an online process. Is that what I'm getting from Wonder Schools? Signing up, doing the education process, doing all that. It's all online?
And here's your answer. Go ahead.
Mr. Chair, thank you, Representative. I'm sorry, thank you, Senator. I apologize.
No problem.
Yeah, so yes, we are a tech company. A lot of our stuff is online. And also we definitely still do some in-person trainings when we find that they're the most useful. So I'll give an example. I live in Oregon. My colleague Tiffany comes into town and she does trainings with folks, providers who we work with there. And so there's definitely some things that we know in person make a difference and they're the right thing to do. And in other cases, you have folks out in rural communities where it's like finding something you can do online and a training you can do online or on Zoom is really valuable if you can't drive into a community.
Very good. Follow up. Go ahead, Senator Hutchins.
Thank you, Mr. Chair. Wonder Schools, it all sounds wonderful. Give me some of the downside of this program, if you would.
Go ahead.
Chairman, that's a tough call for me. I'm not trained to give the downside of it. Let me think of a few things. Well, I suppose one downside could be that, we go into community and help people build businesses and they decide this is just something that's not worth it for me. And then we might lose some providers that way. That probably happens with anyone who comes in and tries to build those businesses, but I don't know if that's necessarily a downside of Wonder School. I'm just thinking of some of the, some of the things I've seen out in communities where we go in and try to build and it's like, well, we found, we thought we found 10 people who really want to do this, and then 3 or 4 decided it just wasn't worth their time or it wasn't worth the amount of effort they would have to go through. So that is a tough part of some of the work that we do. Yeah, I maybe would have to talk to people who don't like Wonder School to tell us things that they've seen in downsides, but yeah, I appreciate your question because I don't want to just say it's all roses and pretty and beautiful. But I will say I work with a bunch of sincere people who truly want childcare to work. They have children and they often have a tough time finding childcare themselves and they're really intent on that. So finding ways to improve the business we do and the work that we do across the country has been, I've seen them be very sincere about that. I will say I worked for nonprofits for many years before I took this job. I was skeptical as well. And I haven't seen a bad side to it yet. So, but I will report back to you, Senator, when I do see something.
Mr. Chair, one more question. I think she mentioned that she would give us some more data, some more information on it. Or is it better to go online to look it up? Whatever you could provide the committee would be great. And thank you.
Senator Hutchins, I was so hopeful you were going to break into song when you were doing Wonderful and Wonder School. You really disappointed me there.
I can't sing, sir. I can't sing, but thank you.
You can't see that the chairman next to me is singing, and we don't want to hear it out loud.
Mr. Chairman.
Shelley, go ahead.
Thank you, Mr. Chairman. And just to give a little bit of extra, my colleague Devin and I went and actually visited some facilities in Nevada a year ago. And one of the things that we were impressed with is one of the things that DFS is working on is to do some collaborations and some centers where all of the different services that that have to do with childcare, children, things like that, they've set up some places like this in Nevada, and where it's a one-stop shop so that providers, licensing, parents, everything can come to this one place and get all the services in that one place. Wonder School participates in that. And one of the beautiful things that I experienced was being able to look and see they actually had like a teacher's lounge where home providers had a place to come locally and get curriculum, to get and borrow in their library, to be able to use a printer or a laminator or all those kinds of things that a regular teacher or a regular center has that maybe a home provider doesn't have. And they were able to do that in Reno and in Las Vegas. And then, of course, you know, DFS was there. I think some of the Department of Health and some of the other all the different entities involved with childcare was in that same building. And then they met weekly or every couple of weeks to collaborate and find out what are the needs of the community and things that they were needing. And so that's something that could be, you know, reproduced here in the state. And I think, if I remember right, one of the presentations DFS was headed that way. The other thing that was really great is I heard a personal story of a special needs teacher who was getting burnt out and ended up with, and she had the extreme life students. And so she ended up opening up a Wonder School for herself and some of her parents that were not getting the kids that weren't getting the attention because of the too many in the classroom. She opened up a Wonder School program and those students were able to go and the parents were able to go and she was able to provide those same services in her home, you know, through Wonder School. So it's got a lot of different potential with our teacher problems and burnout and things like that.
Thank you. Questions? Go ahead, Representative Trujillo.
Thank you, Mr. Chair. How are you guys funded now? What is your percentage of government funds and private funds?
Thank you, Chair. That is a great question. We are a private company, and I would say the vast majority of our contracts are with governments at the state level. We do have some contracts with employers where we go in and we design programs for employers to say, okay, you know what, we want childcare to be a benefit that we provide. And so we contract with them to build some of those new supply that we've talked about, and then also to match children into those services and match parents with those. Does that help?
Follow up. So with Wyoming having maybe 680,000 people throughout the whole entire state, and you're going to try and open maybe 10 of them with test pilots, do you think that's very cost effective to Wyoming?
Chair?
Go ahead.
I do. And part of that is because we know when parents are able to go back to work, there's just a multiplied benefit when we see that, right? When we know that they're able to go back and they're able to make a wage, pay taxes into the tax base, they're just a multiplied benefit. And then also the person who's created the new center, the new in-home care is also able to bring those funds in. So on, I think it was maybe page 7 or 8, it shows some of that return on investment there. And we've seen, yes, I understand Wyoming has less people, but it's also the same, it's really in the same math that explains for people when they're able to go back to work, that they're able to jump in and add more money to that tax base. And employers like that as well, right? They're able to find more employees.
Follow-up.
Follow-up, go ahead, Representative.
So the parents that are taking their kids to Wonder School still has to pay their fee. So do the daycares or the schools of Wonder School, do they increase their costs because they, after 2 years, have to, if they want to continue the program, pay an additional fee? Now, as far as finding substitute teachers and going back to work, I did a quick, simple Google, and I found 3 referrals for babysitters. Do you work with those kind of programs as well?
Chair, thank you for these questions. So we do not work with babysitters. We only work with in an official substitute program where they jump in and they have that state background check. But if there was a babysitter out there who decided to become a substitute, that's completely fine. Of course, they would just have to have that state background check. But we don't work on babysitter programs, or have a platform for them to find a family. And then to your first question about, let me try to jog my memory on what it was, on the cost for providers. So we make it so that after that 2 years is done, if a provider wants to continue on our platform, our CCMS, it's roughly the same market cost as they would for any childcare management software. I think I want to say like $150 a month, nothing like wildly onerous. They also don't have to do that, right? They can jump and use another CCMS platform. And we advise our providers to set a price for their childcare that's commensurate with the community around them. So there's no benefit to us for them to charge more or less. We don't make a cut. It's not a Wonder School program. They name their program what they want to. It's their own business license. They pick their curriculum. And so if they decide to charge too much, they'll probably have a harder time filling their program. If they charge under, it's a market rate, right? They charge under, then they're probably not going to be as profitable or be able to stay in business. And so we don't prescribe to any provider, here's what you need to charge, or we're not going to work with you. That is their own, in the end, it's really their own business.
Further questions, committee? Representative Ward.
Thank you, Mr. Chairman. How do you see this working with House Bill 166, the educational savings accounts that was passed into law and also amended by the governor?
Go ahead.
Chair, thank you for the question. I do not know this off the top of my head. Devin, do you have any ideas?
I don't, but I bet our friend online does.
You're looking for a lifeline.
I'd like to phone a friend, Mr. Chair.
I don't have it in front of me. Is this the ESA bill?
Yes.
Yes. So I'm not for sure about the particulars of who gets to qualify or not, but this wouldn't be any different than any other like preschool or any other program, because think about it. Currently, Wyoming and DFS does not have a requirement to be licensed in order to call yourself a preschool. So there you have it. So yeah, you could apply. I don't know the parameters and the rules and such for that. And if that's even been released yet, I'm not aware, but this would be no different than any other program, childcare centers and such. I'm not aware that home-based childcare was disallowed.
Go ahead, Representative.
Thank you, Mr. Chairman. I'll answer the question. Pretty familiar with this bill, and we discussed this a lot yesterday in education. So as long as the preschool, so not a daycare, but as long as it's a preschool whose curriculum is certified by the state superintendent, any family that's at 150% of poverty level or below would qualify for up to the $6,000 in educational assistance. So yeah, and one of the goals was to have preschool available for these 4-year-olds. So I think as long as your providers meet the superintendent's requirements and get certified by the superintendent's office, they would definitely qualify.
Very good. That was your friend was closer than you thought. Further questions, committee? Seeing none. Thank you very much. Okay, that brings us to the final line of our agenda today, which is public comment, and most of the public has abandoned us. So we would open it up to anybody here who wants to talk about anything we've talked about this afternoon, midwifery, OB delivery, childcare, the co-chair singing abilities, whatever you want to address. Come on up and introduce yourself.
Hi there, my name's Anna.
It's about, push the green button there, or the button that turns the light green.
My name is Anna Lee. I'm a certified nurse midwife. I've practiced here at Cheyenne Regional in Lander, which is
I need you to get
Fremont
closer to the
County.
mic if you would, so everybody can hear you.
And I've delivered zillions of babies up there and down here. I attended school at the University of Washington back in the Pleistocene era. And I wanted to address that there's so much talk about creating new midwives and starting a school, which is cumbersome and expensive at best. We have lots of midwifery schools. And in fact, I'm a preceptor for Frontier, which produces the most certified nurse midwives in the country. And what we do is we grow our own. So we take local, I say ladies, but it can be gentlemen as well, who graduate from nursing school. They're in labor and delivery, and they want to take it up to the next level. So the very, very detailed educational program is online with live teachers and so forth. And that's the didactic portion. And then they come to me, and in the clinic and in the hospital, I observe as they deliver babies and learn all the skills that you need to know about pharmaceuticals and suturing and that kind of thing. So we already have a midwifery school. The problem is you can have as many midwives as you want, and it doesn't do you any good unless they're practicing. So while I can be fully credentialed at this hospital or that hospital, here I am. I can't work there. I go in there, and the legislature has accommodated us and made us fully competent providers that can obviously work in hospitals and clinics, but I can't. I go in there and I go, I want to practice. I want to continue delivering babies. And they said, you can't. And I said, why? And they said, well, you don't have this piece of paper. And this is permission from an obstetrician that says I can deliver there. A family practice doctor like Dr. Sinclair, she doesn't need that permission. No one else needs that permission, but I do. So this is thwarting us. The majority of certified nurse midwives have left, or as I am, about to leave the state to go practice somewhere else. Oh, if you want to see it.
And I said, well, while we wait here, I think we have a question down on the end. Representative Ward?
Thank you, Mr. Chairman. Ms. Lee, you mentioned you can't work at, I think you said Cheyenne, and you need a permission slip apparently from an obstetrician to practice there.
Correct.
What is the origin of this permission slip? Is this required by law?
No, so HUB is the broker for all the malpractice insurance here, and I said, do you require it? And they said no. So I went to Gina, who's the credentialing person here, and I said, does the hospital require it? They said, well, doctors got together and they said, for a midwife to deliver here, she has to sign this collaborative agreement. And I said, well, but the Wyoming law doesn't require it, and the insurance doesn't require it, but they created this.
What, a follow-up, Mr. Chairman? Thank you, Mr. Chairman. So they created, you're saying doctors created this. What gives them the legal authority to have you sign a paper that the legislature says you don't need to have?
Yeah, unknown.
And I
And I
suspect,
don't know how to pursue.
I suspect that's a question that would have been better addressed to some of the folks that have already left, the Board of Medicine, et cetera. But I do know that there are not laws, but there are regulations enforced by hospitals within their, my mind just went blank for the terminology. What's that? Yeah, their bylaws. For instance, in some mid-level practitioners, hospitals specifically can have bylaws or guidelines that they can enforce within their hospital. But the legalities of that we'd have to pursue further. Follow up, go ahead.
Thank you, Mr. Chairman. I guess the question would be to either Ms. Lee or our committee. What could we do to address that? Because she just told us midwives are leaving our state because of this. And this is the question we've been trying to get to for the last 2 meetings. So it's kind of sad. It's at the end of our last meeting. So what can we do? Because here's the problem.
That is a problem, and it would be interesting to hear from the other hospitals to see what their guidelines are. Representative Penn, go ahead.
So, thank you, Mr. Chairman. I think that this comes down to, because you're right, the law does not say that this is required, but it's within the bylaws of the facilities, which are partially based upon probably the boards, who are partially made up of physicians. And a lot of them will likely put up a liability concern, which is not nothing. I mean, if a physician, and we discussed it a little bit in our last meeting, but if something happens and midwives can't do C-sections and an emergency C-section is then required, then the physician has to assume care of that patient. And that, I think, is where the rub comes and why they require these collaborations, because they say, well, I don't know if this person is on call. I don't trust that that person is going to be doing a good enough job that I would then be comfortable to pick up the pieces if something were to happen. I think that's probably the discussion that's going to happen there.
Right, and if that is true, then I would be curious why they didn't require that of all the family practice doctors who have far and away less training than I do, or any obstetrician.
Go ahead, Representative. Let's get Representative Yin quick. Go.
Mr. Chairman, I appreciate it. Ms. Lee, where are the midwives moving to, and are there states where they ban requirements to have a collaborative agreement with the hospital, or force hospitals to take on midwives without collaborative agreements that midwives are moving to? Or is it just because the current hospitals in Wyoming are not willing to take on
It's not the hospitals,
midwives?
it's the obstetricians that are blocking us. And so I don't know, I can give you personal. Chase was practicing in Fremont County, delivered so many people, and hospital said no. So she picked up her husband and 4 kids and moved to Billings. We have Mandy, who's in Rock Springs, and the doctor there doesn't want more. There's one midwife, but she's been there forever, but they don't want her or me. And so she goes to Utah, where there are massive midwifery teams, 12, 20 teams. And Utah's got it right. I mean, everywhere you go, they have huge midwifery teams, which are incredibly cost effective in reducing C-sections and Medicaid reimbursement.
So, Mr. Chairman.
Go ahead.
Ms. Lee, do you think that it's more about personalities of specific obstetricians that
I
do
don't know
not
about
work?
personalities. I think if you ask, like, why would a team of doctors at any hospital say, okay, you have to have this piece of paper to work here? Why would they think I would threaten them in any way?
And I think an impartial answer to that, I think Representative Penn hit on a piece of that, is that if there is follow-up care needed, if somebody has to assume care after the doctor, be it the obstetrician, if they have one, or the family practice, needs to follow that up. So there needs to be an agreement there with those doctors.
If it were true that there were greater bad outcomes, then of course it would be reflected in the market, and we'd go to malpractice. So when I work here, or when I work in Fremont County, I'm folded right under the malpractice agreement of the physician with not an added penny, because the chance of a midwife being in a malpractice suit is so minuscule and so remote that they don't even charge an extra premium for it. So there's your, it's where they follow the money.
I would add one more thing to that discussion, because you mentioned somebody that I've worked with, Mandy, who works in Rock Springs.
Yeah.
I worked with Mandy in Kimmer, who delivered babies in Kimmer.
Yes.
The only reason she's no longer doing that is because Kimmer closed down their OB practice.
Mhm.
But she was delivering with the agreement of the doctors there, was underneath their medical protocol. So there are some being delivered, not as much. And I sense that it's more of a personality thing than anything. I suspect, and we've seen it before with mid-level, we've seen it across the board. But that being said, Representative Clausen.
Thank you, Mr. Chairman. My thought here is, looking at my local community, we have a publicly elected hospital board that they set the rules. So I guess my suggestion to you, I don't know if have you gone to the board of these institutions? I'm not sure the state should be telling these publicly elected hospital boards
Right.
how they should be running their business. So I just didn't know, have you gone to the board of the hospital?
Okay, it's not an option in Fremont County because we're owned by Apollo Private Equity, an investment firm out of New York City. So they don't seek our counsel. But I can try other hospitals and see. But anytime we're pitched, a physician wants to make money. So if they see someone else taking a cut of their pie, then they're gonna.
Just a quick suggestion here, and that is that this is something that needs to be brought up more, needs to be talked about more, absolutely. Further, I think it needs to go to this subcommittee from that's exploring this thing, bringing folks in and talking about this topic, because as one of the doctors said today, or somebody said today, I don't know who said that, but you can't tell a doctor you've got to get along with somebody. And so there's the rub.
Well, I have great relationships with my
Right.
doctors, but my guy up there, I mean, he has health problems. I knew 2 years ago he's gonna close the clinic, and so poof, that's it. I mean, our
Understood.
nurses don't leave. Our doctors, I've worked with I precepted some of these residents, and they all leave. I mean, she said she's staying, and that's great, but nurses, born and raised, they're not going anywhere. And I got 2 girls lined up, so as soon as we get our new hospital in Riverton, they'll start the didactic this fall, and we'll be ready for them, so they can work in their own community.
Understood.
Mr. Chairman?
What? Go ahead, sir.
Ms. Lee, is the hospital that's being built in Riverton also owned by Sage West, or is that one?
Oh, no.
So,
No, they,
good.
I think, they raised something like 43 million, and they're gonna be associated with Billings Clinic.
That's good to hear.
Oh, it's very exciting, yeah.
Good.
Yeah.
Representative Ward has something, I believe. Go ahead.
So I just have a comment, and not a question for
We
Ms.
can
Lee.
make it a question. We can make anything a question.
It's unfortunate that we're at this point trying to get at the answer to the question, what is driving midwives out? And here is the answer, and we're not able to address it, sadly.
I mean, if a woman goes into a hospital and you say, or a clinic, would you like this old midwife to take care, or would you like this, this male surgeon, they're like, well, no, I want, the midwife to take care of me. And so there might be a certain amount of competition there, but I never woke up in the morning wanting to compete with anybody. What I think we have really good mortality and morbidity rates in every place we have a midwife. I think it's something to be proud of. And every obstetrician I've worked with thanks me for every solid night of sleep he gets.
Very good. And I would say, and use an example, I think you've opened up or put light on a problem that's there. You've opened up the wound. That's a terrible, terrible example, but you've opened up something. We see where the hemorrhage is. We know there's a hemorrhage. We know there's a problem. And you've opened that up where we can see it a little bit better. Now we need to not end this conversation here. Those who are staying in the legislature and those who are lucky enough to be on this committee again, and those who are associated with the OB subcommittee, we need to not let this go. We need to explore this further. And I don't know that we're going to find the answer easily, but we need to see if we can find an answer. If anybody has the answer now, please jump forward. And that's what I thought.
Free market.
Yeah, but it is something that needs to be worked on. We appreciate you coming
Thank you.
and sharing with the committee. And thank you for your work.
Oh, thank you.
And keep up the good work. Okay, any further public comment? Welcome to the hot seat. Introduce yourself. We know who you are, but tell us again.
Members of the committee, thank you. Tony Decklever with the Wyoming Nurses Association. And I have been having some conversations with some of the nurse midwives around the state. one of the barriers, and to Representative Ward's point, is that even though advanced practice registered nurses have what we call full practice authority, so they don't have to work with a physician. They don't have to. They can put up a shingle, they can see patients, and they can order meds, they can order treatments, they can order procedures. What they cannot do is admit to a hospital. And under our statute, so it is chapter 35. There we go. Chapter 35, it says, doctors of medicine, osteopathy, chiropractic, dentistry, or podiatrists may practice in public hospitals. So, and then it says any hospital owned by the state or any hospital district, county, or city thereof, and any hospital whose support either in whole or part shall be opened for practice to doctors of medicine, osteopathy, chiropractic, doctors of dentistry, podiatrists who are licensed to practice medicine or surgery in the state. And so even though we can hang a shingle, we can order and do all these things, nurse practitioners cannot admit to a hospital. So if someone needs to go to the hospital, they have to go through the emergency room, which is an added expense, and then they are admitted under the hospitalist or whoever happens to be on call. And so in Virginia, they actually passed legislation that states clinical privilege for certain practitioners. And they put in there that the grant or denial of clinical privileges to licensed podiatrists and certified nurse midwives, licensed as advanced practice registered nurses in the state of Virginia, can have privileges. Now, we know that in order to receive privileges, a provider has to go through the privileging process. And every hospital has a privileging process where they look, because we know that there are some doctors that don't receive privileges for a variety of reasons. I mean, they have their bylaws, they have their rules and regulations that they have to follow. But PAs and nurse practitioners are not part of this. And we actually tried to put nurse practitioners in this statute years ago, and it was shot down. It was like, no, because there was going to be a massive problem with nurse practitioners being able to admit. But, and part of it is because of this, they cannot take care of people in hospitals. And there was a statement years ago when a person said, well, nurses can't take care of patients in hospitals. And we just all kind of cocked our heads and went, what? Who do you think is taking care of patients in hospitals? So anyway, but nurse practitioners, yes, family nurse practitioners, their education is primarily in an outpatient type of place, absolutely. But we have psych nurse practitioners that work in psych. We have nurse anesthetists that work in hospitals. We have CNMs. And so if a nurse midwife could specifically admit to a hospital, then they could see their patients, they could admit them to the hospital where they would be in a safe place. And honestly, and I understand Representative Penn's statement, but I'm an old labor and delivery nurse. So we would have people come in under family practice, and they would be, moving along, laboring well, and then something drastic would happen. You've got to call the OB. So the OB hasn't established a relationship with this person either, and they're already in the hospital setting. So, I mean, I understand that, people coming in and there's no relationship, but that can actually happen when a patient's already in a hospital being treated. So that might, if we were to allow even nurse midwives to be able to admit to a hospital, then they could see patients under their shingle. And then when they got ready to deliver, they could actually go into a safe place and deliver, and you wouldn't, and if we needed an OB or, a specialist, the chances are a little bit better.
Thank you, Mr. Chairman. What was that statute you quoted from again?
It is, I'm sorry, Mr. Chair, and Representative Ward, 35-113.
Go ahead, Representative Ward.
Thank you, Mr. Chairman. I'd like to move that we add certified nurse midwives to Wyoming statute 35-2-113.
That would require a bill draft, and it's a great idea, but we don't have another meeting. So what I would suggest to you is that perhaps you consider this as an individual bill, but I would suggest that you need to get together with Tony. I would suggest you need to get together with the PA Association and then, as well as the Nurses Association and put together a bill. That would be the proper, because we don't have another meeting, otherwise we would do it. Senator Barlow has a question.
Thank you, Mr. Chairman. So, and I haven't had a chance to look up this statute yet, but it seems like, I think it's very specific to county hospitals, county memorial hospitals. In that particular statute, you have to go also, we need something broader because we have actually 4 different types of hospital systems in Wyoming. We have hospital districts, we have county memorial hospitals, we have private hospitals, and then we have state-run facilities. So I think that while I think this gets to 1, county memorial. And like I said, I haven't got to look it up yet, but I think this just gets to 1. The second thing I'd say is that if we are looking at this in that restrictive a manner, then that would indicate that these hospitals, if they're employing any of these people now, that is, they're not authorized to do so. And I would suggest there are hospitals that are employing some of these folks already that are not included in this list. So I just throw it out there that 1, there's more hospital types. There's more hospital types out there that if we want to get to this issue, we're going to have to look elsewhere as well. And 2, that doesn't mean that those folks actually get privileges. It just puts them on the list. So I think it's a step. I don't know that we got to get more details and see if there's actually another mechanism that we can leverage this. I agree with your thoughts, Mr. Chairman. This needs to go to that OB working group, and some of these folks need to get together and help give us some feedback. And I'll be glad to be a part of the solution and the discussion, but I think this is bigger than just that 1 statute. Thank you, Mr. Chairman. Wouldn't you agree, Ms. Decklever?
Mr. Chair, Senator Barlow, thank you for that. Yes, I agree. One of the things to add to that, though, so I spoke with a certified nurse midwife from Laramie, and she actually she's employed by Ivinson but she is employed under a physician group. So, and I asked her, I said, so your patients come to you. I said, but you're under the doctor's name. And so when a patient is admitted to the hospital to have their baby, they're admitted under the doctor's name because the nurse midwife works for the doctor. So can the nurse midwife deliver in the hospital? Yes, but they're admitted under the doctor's name, and so they're paid by the doctor's paid, and then they pay their employee. So she's actually doing the work inside the hospital. She also told me that she actually has a pretty good working relationship with the CPM in Laramie. So it was a very nice model of if the CPM had a patient that was, she had some questions about, she would call the nurse midwife. And if the nurse midwife felt like that needed to go up to the obstetrician, then it followed this path to take care of this person. So they had she said, we have a great working relationship with the CPMs. And to the point that it's been brought up several times, it really is about relationships. Because you can have a really good working relationship and it works well for the patient. But if there's kind of an adversarial working relationship, it doesn't really work. But again, I find it interesting that a midwife that is employed by a physician office can go into the hospital and deliver the baby. But if the midwife has her own practice, she can't go in and deliver the baby. So it is something that we probably need to think about. It's just one more component.
Very good. Further questions? Seeing none, but I would follow the suggestion of Senator Barlow and would recommend to Representative Ward, Senator Barlow, as well as with you, Tony, is that you do need to go to Jen and you need to go to Sheila with that working group and put this, it's on the radar, but you need to emphasize it on the radar and make it a bright light because it needs to be pursued further, be that an individual bill this coming session, be that something that comes up in the interim next time, but it's something that does need to be addressed and something that needs worked on. So.
Thank you, Senator Barlow. I will tell you that I had a meeting with Sheila Bush last week and we talked about that also. So yeah, we'll follow through.
Very good.
Thank you.
Thank you very much. Any further public comment on this or other topics? Going once? Oh, go ahead, Representative Yen.
Mr. Chairman, thank you. Maybe just a note, we had a doctor in front of us that was an OB that talked about how he got burned out in Lander, and we have another issue where we have a certified nurse midwife having an issue in Lander as well. Lander, I believe the Hospital Association mentioned this once. Sage West is our only private hospital, private for-profit hospital in the state of Wyoming.
Not true, not true.
Okay.
There is another.
But do we need, we do have oversight with communities, with hospital districts and memorial hospitals. Do we need a little more oversight on for-profit hospitals in the state of Wyoming? If it's causing issues for actually providing healthcare in our state?
Write that question down and keep bringing it, because you're going to be on this committee forever.
You want the government to take over private business?
Okay, any further public comment? We're going to close public comments. It's closed. Committee, anything as a directive for LSO before we adjourn tonight?
Good evening.
Nothing? This leaves me time to go to the burger place where Five Guys make hamburgers and go home and watch a football game. Okay, we'll adjourn for the evening. We'll see you again tomorrow at 8:30 a.m.